Okay, thanks very much, Chair. Firstly, I would just like to remind everyone that these proceedings are being recorded and will be made available on the website of Dundee City Council and the Partnership for Public Viewing. I will now take a roll call of the membership for the minute of the meeting, and I would ask that members confirm they are present when I call their name. Councillor Lynn.
Present.
Pat Kilpatrick.
Present.
Councillor Toland.
Present.
Councillor McHugh.
Present.
Anne Buchanan.
Present.
Donald McPherson.
Present.
Dan McCulloch.
Present, Willie.
And I've received apologies from Vicky Irons. Dave Berry.
Present, Willie.
David Wilson.
Present, thank you.
Sarah Dickey.
Present.
Dr. James Cotton.
That is very much supported by the state.
Mark them as absent and present. And I've received apologies from Raymond Marshall. Jim McFarlane.
Yeah, I'm here, Willie.
Thank you. Christina Cooper.
Present.
Yeah. Martin Sloan.
Present.
Dr. Emma Fletcher.
Please help me out if someone's got the exact
Present,
statement.
thanks.
I think someone may have their mic open. Dr. Shaw.
Present.
Thank you very much. And that concludes the roll call. It takes you on to the agenda as submitted, and I've covered apologies. It then takes you on to declarations of interest. It's well not any members of any declarations to the content of the agenda as submitted. And there being no declarations, then it takes you on to item 3, which is the outgoing chairperson's remarks.
Yeah, thank you for that, Willie. So, as you probably all know, but if not, I'll tell you, the chair rotates every 2 years between Dundee City Council and NHS Tayside, and my 2 years has now come to an end, so I will be handing over to Pat Kilpatrick. It seems that leadership changes are in vogue at the moment across the country, so I don't suppose there's any reason why we should be any different. I am not going to try to hand on to power, and I will not attempt to make a return to power, at least for the next 2 years, so you have that guarantee. So much of my 2 years as chair has been dominated by the COVID pandemic and the partnership's response in what has been extremely trying circumstances. I'm really proud of the way in which we continued to provide a quality service to our people during that very difficult period. And in particular, the frontline staff who provided continuing care to the city's most vulnerable at a time when there was really quite a lot of panic about COVID and a lot of people became seriously ill, ended up in hospital, but our frontline staff continued to go to work and provide that care that people need. So a really special shout out to them. We have, of course, had other challenges during the 2 year period when I've been chair, not the least of which has been the pressure on GP services, with one surgery closing during my time. On a brighter note, we're seeing innovation and delivery of GP services in primary care. And I think that the 2C practice in Lochee is a shining example of that. It's a practice which is thriving. And I know that Siobhan and I are going up there to visit soon, because that's why she sent me an email at 6 in the morning. Yeah, but this I think will continue to be a challenge over the coming years also. Two of our really big priorities for the next 2 years will be continuing to address and improve the issue of mental health, and continuing to improve services for people who use substances. I'm really looking forward to the opening of the Community Wellbeing Centre soon, and the provision of accessible 24/7 support for anyone in distress with accommodation provided where necessary. And of course, we've also seen the development of the mental health ambulance service, and I met with them recently, late at night when they were carrying out their duties, and was very impressed by this service and how it's helping people who are in great distress with their mental health. So that's another positive. The partnership will continue to focus on reducing drug deaths in the city with a target of 0, because I don't think we can ever accept even one death as being acceptable. It's been a huge task, and particularly during the pandemic, as I've mentioned. There's a great deal to be done. And although we've seen quite a significant fall in drug deaths over the last 2 years, we will have to redouble our efforts. And I'd like to single out the work of the non-fatal overdose team for special mention. They contact anyone who has had a non-fatal overdose within a very short period of time, and then set up the services that need to be put in place and probably haven't been in place, which has led to them almost dying. The non-fatal overdose team received a COSLA award for the work that they're doing. So I think maybe it would be good to have their team leader, or whatever the title is, along to one of our meetings to maybe talk us through that very valuable work that they're doing. So I guess that's it from me. I was trying to remember that thing from the two Ronnies. It's good night from me, and it's I can't remember it. So, and you'd have to be of a certain age to laugh at it, so I won't bother. But yeah, I'd really like to thank everyone from management down to our frontline staff who have provided services over the last 2 years and who have been so kind to me. I have a really good relationship with the management team. I'm not sure if they have with me, maybe that's just in my imagination, but I think that's the case. And I certainly have a good relationship with Pat, and long may that continue, and may we continue to work in tandem to make sure that services in Dundee remain optimum. So thanks very much, and that's it from me for now. So it's over to Pat. Thank you.
Thanks for that, Ken. And I think it was really important to hear you reflect on your time as chair and some of the achievements that the IJB, the Health and Social Care Partnership, have taken forward. As ever, it's always a great honour to chair committees like this, and to follow in Ken's footsteps. Big shoes to fill. So I'd also like to pay tribute to my former colleague, Trudy McClay, who worked very closely with Ken. And I know she valued that working relationship that you guys had, so that I can go some way towards emulating that, because I know she was very highly thought of. So thanks for that, Ken. So we can move on. And the next item in the agenda under section point 3 is the vice chair. And so what we're doing here is we're swapping around here. So we need to fill that in terms of standing orders. Remember, it's got to be filled by a voting member of Dundee City Council, and Dundee City Council have nominated Councillor Ken Lynn as the vice chair. So that gives us some great degree of continuity here, and I hope you'll all congratulate Ken on taking up the vice chairs. Okay. If you're happy with that, Ken, I never asked you there. I know you've been nominated, so I assumed you were asked when you were nominated. Are you happy to do that?
I've mulled it over this morning and I've decided to accept.
Great, that's great. Great news. So duly noted that you've accepted. So congratulations and thanks, Ken, for that. I think what we're called the dream team, aren't we, Ken? Aren't we?
Well, actually, that was Trudy and I, but I'm sure we can come up with another suitable title for our partnership.
Yeah. Okay. Right. So, so Ken is duly elected to become the vice chair of the IJB. Moving on to point 4, the Performance and Audit Committee, appointment of the membership and the chair. Now, I was previously chairing this committee for a very short period of time, so I only joined the IJB in February. So I will no longer be able to stand as chair, but before that, we'll just look at the membership issue. We'll appoint the committee will consist of not less than 6 members of the IJB, and that's 4 integration IJB members, 2 from NHS Tayside and 2 from Dundee City Council. So can we just deal with the City Council first? Have we got 2 people nominated, Willie?
Chair, yeah, thanks very much just for introducing that particular item. Yes, certainly, as you're saying, with the changeover in office bearers in the IJB, this would also have a change over of the voting members on the committee. And as such, we'll be looking for the new membership to be Councillor Lynn, Councillor McHugh, and Anne Buchanan and Donald McPherson. And custom and practice would be that we're looking to appoint the chair, and the chair would be Councillor Lynn for this particular committee. So the Integration Joint Board is asked to agree to that composition and chair.
Can I just stop you there, Willie, because the reason that I'd like to interject here is that Donald McPherson will come off the IJB in November. Is that right, Donald?
I'm not entirely sure when I'm coming off, Pat, but I know it's, I think it's as soon as the formalities can be going through.
Yeah. So can our nominees be Annie Buchanan and Sam Riddell onto the Performance and Audit Committee? Those would be our 2 NHS Tayside voting members. And I will stand down from that committee and let my colleagues play their part in that. They both have good contributions to make, as do the 2 councillors. So if everyone's happy with that, we agreed. I'm assuming unless anyone has anything else to say, they were agreed with these, with the composition of that committee. And Ken will chair it. That's the case, isn't it, Willie?
Yeah, thanks very much. Chair, happy to accept that appointment.
Right. Okay. So that's Ken.
Does that not have to be formally agreed? No.
Yes, it does.
Yeah.
So have we got agreement on Ken Lynn as Councillor Lynn as the chair of the PAC committee, with Annie McPherson and Sam Riddell as the NHS members, and Councillor McHugh, was it? And Councillor Toll?
No, the D members would be Councillor Lynn, Councillor McHugh, and the NHS members, as you've indicated, would be Anne Buchanan and Sam Riddell. So they're appointed, and the Councillor Lynn, as you say, has been agreed to be appointed as chair.
So is everybody happy with that? We got agreement on that?
Yeah, Willie, could I ask if you could send the dates out, please, for me to get them in my diary? Thank you.
Thank you very much. We'll arrange to get that done.
Yeah.
Okay, thanks, Sean.
Sorry, I was just going to say, Willie, I think for both, for all the new members, I think maybe an opportunity to either meet with the outgoing committee or meet with Ken and just look through the terms of reference for the PAC and the work programme for the coming year and some of the issues that remain outstanding on the action tracker, just so you as a group can get a feel for where that committee was going and some of the issues that were coming up. Is that okay, Willie?
Yeah, appreciate that, Chair. We'll get that done.
Right. Okay.
Thanks very much. It takes you on to item 6 then before you, which is the minute of the previous meeting of Integration Joint Board held on 24th of August. That's submitted for approval.
Okay. Any points or questions, inaccuracies, changes, edits on the minute? I'm not going to go through it because I know you've all read it. So if we got approval on that, yep. Okay, Willie.
Thank you very much. There is the accompanying action tracker, which is submitted for noting.
Yeah, there was quite a few things on this that had been there quite a long time, which I queried with Dave. Dave probably thought Pat's turning into my pen friend online. there were a few that seemed to go, and I said that I don't think that can be right because I thought it's the same year. But if point 2, the suicide prevention strategic update, it says held on the event was held on the 23rd of November, and I'm saying to Dave, oh, that can't be right. That must have been 23rd of September, but it was actually the 23rd of November 2021. So I think we're still waiting on the outcome report from that meeting and the final draft of the plan, the suicide prevention strategy update. We're still waiting for both of those, and they're coming in December. Is that right, Willie?
I believe that's the case that the partnership may be submitting it to the December meeting. Yeah.
Yeah.
Well, I think Dan might want to come in on this one.
Yep.
I see Dan's hands up. I know Martin's want to come in as well.
I'm
Thanks.
happy for Martin to come in first. He may sit on the group, but Chair, it's just to say that this had been a long-standing issue about the fact that we're waiting on this work being done, and I think we probably need to just look to see, as was said, about when we can submit a report and how we can take that forward. So I would acknowledge the timing of this has gone on for a long time. We need to consider where we go next, but we are planning to bring something soon.
Is that the December meeting?
I'll be happy to confirm afterwards where we are with it, Pat, and make sure it's included for the action plan going forward if it's not going to be December.
Okay. Any comments from board members on any of that? Thank you, Diane. No. I mean,
Chair, I think Martin
Wait.
wanted to come in.
I didn't see. Sorry, I didn't see a hand, Martin. My apologies, Martin.
That's all right. I was just going to come on a different topic actually, but I don't know if Dorothy wants to continue on that topic or not. If she does, I'm happy to defer.
And then we'll come back to Martin. Is yours relate to the suicide prevention strategy, Dorothy?
Yes, this was one of the things that I noted on the action tracker as well. The time delay for the suicide prevention update. And considering what we've just heard from Diane, it's not sounding terribly hopeful for December. And that concerns me a little. I know there's a lot of work to be done, but this has been hanging around for quite a long time now. Thank you.
Okay. Thank you, Dorothy. I think I don't know if I can say most of the committee members would share your concerns, but I see a lot of people nodding, and I would certainly share your concerns. I think it's too long. I know we've been in a pandemic, but we need to get this to get it published and understand how it's being implemented to support people. Sorry, Martin, did you want to come back now?
Yeah, certainly. It was just on a separate topic relating to the action plan. My memory, as good as it is, recalls that we should have an action relating to the lack of service user representation. I remember at a previous meeting we said we'd put an item on the action tracker for that, and I noticed it's not there, so I just want to query that.
Okay, can somebody respond to that, or are we just going to accept that we did minute it as such? I see Dave's got his hand up, and I'm not sure who else has got their hand up.
Yeah.
Sorry, it's Siobhan. Yeah, my apologies, Siobhan.
So do you want to be respond to that one first? Is that okay?
Yes, please, Dave.
Okay. Martin did mention this to me yesterday that that had been kind of noted as an action, or certainly been raised as an action before. So we'll make sure that's added to the action plan. I'll pick up with Vicky and when she's back, and Willie around kind of the filling of that particular post, because I know we have kind of made some attempts to try and get that done through our normal routes, but I don't think anything's come to fruition there. So we're kind of recognising it as a really important kind of position on the board that's not been filled now for around about 6-7 months. So we'll kind of certainly note it as an action on the action tracker and make sure that the position is filled as soon as possible.
Okay, thank you, Dave. Siobhan, you wanted to come in?
Yeah, sorry, I'm actually going backwards now to the suicide prevention plan. And I'm going to echo Dorothy's comments that there is an awfully long delay here. If if we don't get any further forward in December, can we agree as a group that we will get a date as to when this could be resolved? And if not, why not? And what the milestones are needed in order to complete that date? Because I'm aware that, you know, the date was June 22, the November 23 is causing issues, but it would be good to kind of make sure that we know that we have a deadline for this so it doesn't continue on and on. No offence, Diane, but it's good for us to know the focus.
Diane?
So I'm just going to start with an apology. Colleagues really should have spotted that one, and the action tracker is still showing that it was related to the original November conference. I have tried to get hold of one of my colleagues who's the person who's leading on this, but I'm not able to get her. But as soon as I get her, I'll make sure that something comes out, just updating the position and confirming the dates. So again, apologies. I just didn't spot that that was still there when I was updating the action tracker.
Okay, can we get dates and milestones so that we know when it's coming back, and if there are obstacles, if it's a resource issue and we don't have enough people to complete that, a plan as to how we're going to address that? Would that be okay? Are you happy with that, Siobhan? Okay, that's great. So we're accepting the action tracker. Okay, Willie?
Yeah, thanks very much, Chair. Takes you on to item 7, Performance and Audit Committee. You've got before you the minute of the previous meeting of 28th of September 2022 for noting, and the accompanying Chair's Assurance Report, which is also for noting.
Okay, any questions or queries? This gives that's the kind of audit trail for those of you who are joining the Performance and Audit Committee as to where the last meeting got to. And Dave provided support to me as the chair on that committee. So any questions, I think Dave could probably answer them. We're accepting that, okay?
Okay,
Siobhan?
thanks.
Sorry, Billy. Siobhan's got her hand up. Yep.
I'm so sorry, because I knew there was something else I wanted to kind of highlight. It is the 1/27th, the 10/21 mental health and wellbeing planning in light of the impact of COVID. It was noted that something, you know, it says to note following inquiry from Councillor Short that the Chief Officer would examine the possibility of briefings being held for the membership of the Integrated Joint Board on protected characteristics. It's said to be arranged following the new IJB membership confirmed from June 22. But as far as I'm aware, nothing has been arranged on that.
Okay, do you want to come in there, Dave?
Yeah, we'll kind of, so I'm just trying to see that on the tracker.
It's number 7.
Yeah, got it now,
sorry.
number 7. Yeah, got it now. Yeah, I don't know, Dan, if you want to come in on that one at all. I don't know if you just appeared on screen there. So.
I remember the history of this one. I'm sure Catherine would be the person to mostly come in, but I think Bailey Wright had asked if there was data and information which was showing the impact of COVID at the time that we were in the middle of the pandemic, and at that stage there was no data or information which matched the request, so it was held on to the action tracker with a view that if that information ever came in, then maybe we'd do a briefing, and up until now probably hadn't been, but Catherine could probably give the most up-to-date version, but that was the history of the action, Councillor Toland.
Okay. Sorry, it's just that that's not what it says. It says to be arranged following new IJB membership. So the implication is that once the new membership came post May, it would happen. So maybe just clarity there.
I may have got that wrong. Can I also just say I'm having terrible IT problems, so I'm only picking up half of what's being said. So apologies if I think I've got the question and it's not right, but I'll just keep trying. So my apologies.
Okay, thanks, Diane. So it needs to be reworded really to reflect, and we need to know what the actions are going to be coming out of that. Okay, Willie.
Okay, yep, thanks very much, Chair. Takes you on to item 8, which is the management of delayed discharges, and I believe there's also an accompanying presentation with this item.
Okay.
Good morning. Hopefully there's an accompanying presentation. I've got Martin lined up in the background if that doesn't work. And also I am quite full of the cold, so apologies, there may be sneezing. Now, is that showing?
Yes.
Yeah, we got it, Jenny.
Okay. Unfortunately, Lynn Mormon, who is the unscheduled care lead, is off, so I will do my best to do this justice. But I just wanted to start by setting this in a bit of context. So the work that we do locally is part of the National Unscheduled Care Collaborative, and much of the work of that initially centred around 6 essential actions. I would say that in Tayside we've been at the forefront of that work, and much of the national strategy was based on work that was undertaken in Tayside and Dundee in particular. So there are 4 work streams as part of that. We've got interface care, optimising discharge, alternatives to admission, and what will predominantly be the focus of this presentation, discharge without delay. More recently, we've been, the government have reset the programme, and we've got 8 what are described as high impact changes. So we were asked to undertake a self-evaluation locally, and this is between the 3 partnerships in NHS Tayside, the Unscheduled Care Board. We were asked to identify 3 high impact changes to take forward. We chose in Dundee to do 4, so we're taking those areas forward. Discharge without delay really focuses on improving our discharge pathways, and this sets out some of the actions that we're taking forward. We've seconded a member of staff to support the rollout of predicted date of discharge. We've embedded staff in ward areas, working towards 7-day working, and working at the moment in particular around trying to improve morning discharges so that more people are discharged before midday. But probably around the history of this, just to demonstrate the work we've done to date and how that links in. In 2017, we started by creating the acute frailty team. We then opened the acute medicine for the elderly unit in 2018 with originally 12 beds, and we increased that to 20 in October 2019. During that time period, we also introduced DEXA, which is our hospital at home team. We did some work as part of the HIS Frailty at the Front Door project around the direct admissions pathway through the emergency department, created an integrated Tayside-wide discharge hub. We enhanced our community services quite significantly, started the programme of recruiting advanced nurse practitioners, and introduced our planned date of discharge local policy. And you can see from this slide the impact during that period of these interventions and the general downward trajectory in our delayed discharges. During that period as well, we also worked Tayside-wide on our older people's standards. These are a Tayside-wide agreement, they're clinically led, and basically the fundamental underlying principle is that assessment should not take place in an acute hospital setting and should happen as close to where that person is and ideally in their own home. And I suppose of particular importance that people shouldn't be admitted to a care home from an acute hospital setting. So at that point, we introduced the assessment at home service. That was initially 120 hours. And we target that in the first instance on people who were assessed within hospital as likely to require a care home admission. The service provided up to 24-hour care at home and allowed that assessment to take place at home. And that really exceeded our expectations. We supported 131 people during that evaluation period. And as you can see from the outcome slide there, a huge number, far in excess of what we'd expected, were able to stay at home without care, with care even following that assessment. So the planned date of discharge work, this is a bit more detail and I'll not go through all of this, but this is the work planned towards the rollout of the planned date of discharge. And a process map on how we implement that and award. a number of actions that we've taken forward just to support effective multidisciplinary team working on award, including whiteboards, team engagement, clearly defined purpose of the multidisciplinary team, roles and responsibilities, and so on. This is information that we get daily, and it sets our kind of delayed discharge matrix and our targets. Just to show the data set here that we get around discharge without delay, and again, Tayside performs really well in this respect, and across Tayside we average close to or around the 98% mark. So discharge without delay, it really builds on our frailty at the front door work. We've established a Tayside senior steering group for discharge without delay, actions with measurement plans and data coordination. We're involved quite heavily in the planned data discharge rollout across Tayside. We've recruited a Band 7 lead to the team to roll that out. We're in the process of installing e-whiteboards in the wall areas to support the electronic element of that. And we continue to develop the Tayside discharge model. We're now focusing on, if you like, we've done a lot of work to date in terms of the frailty at the front door, and we're now focusing our attention on making that front door more community facing and preventing people from getting in. So I'll not go through this slide in detail, but that really describes our ecosystem around urgent care. Urgent care we define as being illness, injury or deterioration that needs urgent or same-day attention but is not life-threatening. So really where people can be safely supported at home without admission to inpatient facilities. So I would say that this work is really focusing on the end bit of this diagram, so enhanced care, hospital at home, and that pathway into acute. Excuse me. And again, this is a bit of our action plan around the cluster focused frailty model. So we've been doing a lot of work to strengthen our links with the third sector, ensuring that primary care leads are involved in the development of the model and moving towards a cluster model. So that model now involves our MFE team right across the inpatient and community working across clusters. We've pulled together our enhanced community support and hospital at home teams to be one single coordinated urgent care service. And that's now a single multidisciplinary service split east and west, covering 2 clusters each. And that really just describes some of the other work that we've been involved in. So the development of the transition team, ongoing development of the home first model, and a more recent development, we are starting to create a transitions team, which is an AHP team, which works between the hospital and the community to create a more seamless pathway. Ongoing development of the advanced nurse practitioner and other advanced practitioner workforce, and strengthening of the GP cluster model. Oops, me. So that's a very quick run through. I'm happy to share the slides because there's obviously quite a lot more information on them than I've been able to go into and answer any questions.
Okay, Jenny, thank you for that. That was excellent. And it's so good to see the entire range of work from the beginning of the pathway right through. So I think it would be really useful for us to share the slides. If you could do that. They're such good slides. There's so much information captured in them. So my thanks to your colleague who put it all together. I know you've just had to come in and present somebody else's work, and you did that with great conviction and confidence. So thank you for that, Jenny. We appreciate that today. So I've got a few people with their hands up. I've got Annie, I've got Dorothy, and I think I've got a few others. I'm just looking, it's hard. I've got Donald. It's hard to see on the screen. So I'll start with Annie and then Dorothy, and then we'll go to Donald. Okay, Annie.
Thanks, Jenny. Exciting developments. Interestingly enough, when I think back to my career in older people's acute care, some of what we're putting back in we used to have in the old days. I'm thinking specifically of, really effective multidisciplinary team meetings, and the whole orthogeriatric link is hugely important. One of the things I wondered, and forgive my ignorance because, as you know, I haven't lived in Dundee for a while, where are all our minor injury units, Jenny? Do we have them? Have they gone?
We don't have minor injury units. We've got them in Perth and Angus, but they've never been developed in Dundee for historical reasons. But what I would say is the way that the emergency department operates has a minor injury work stream. So it's done that way. I think there possibly is opportunities to develop that further though.
Well, yeah, because I mean, again, you were saying that it's about trying to keep people out of that very acute service unless they need to be there. And injury is one of the things that I didn't know. And I think it's something that maybe we need to kind of revisit so that
absolutely.
we're not dragging people into Nine Wells unless that's really where they need to be. So thank you, Jenny. Lots of exciting work. Hopefully when I'm out doing my clinical visits, fingers crossed nothing else happens, I'll get to pick up on some of this really good stuff. So thanks.
Thanks, Annie.
Okay, thanks, Annie. I've got Dorothy now. Dorothy?
Yes, thank you. I need to see the slides because there was an awful lot of detail there that, I couldn't even see it on my screen. So I would welcome a copy of the slides so I could look at it more closely. One of the questions I wanted to ask was about older people's or user engagement in the whole management of the policy or the frailty pathway. I'm not sure what the words to use here, but I think you'll understand, Jenny. There used to be a frailty strategic group, which I don't believe meets any longer. Is there any user involvement, and to what extent is there user involvement in these plans and policies?
Yeah, so there has been, as you've said, quite considerable involvement through the Frailty Strategic Planning Group when that was meeting. There is still an intention to get that group up and running again. We haven't been able to have the infrastructure to support it through the pandemic. So I would say that user engagement is and has been a key part of developing that strategy. I think though I'll need to take back the specifics around some of the more detailed work about PDD and ask that question, Dorothy, and come back to you.
Thank you.
Thanks, Jenny. That would be helpful. I've got Donald, and then I've got Sarah Dickey, I think, has got her hand up. Yep, Donald.
Yep. Yeah. Thanks, Pat, and thank you, Jenny. Yeah. I mean, I'd love to have a read of the slides after the event. But I think you put over the key points really well, given as Pat says, you were trying to deliver someone else's messages. So thank you for that. First point I was going to touch on is coming back to what Annie mentioned just a minute or two ago, and this issue of not having any minor injuries unit across the city, because that came up, I think, was it maybe at the last meeting or at the PAC in another context when we were talking about falls, and it just felt like we were taking people with minor injury sense of the term into an acute setting that has enough challenges to deal with already, and that's probably not helpful either to the system or, more to the point, to the patient. So I think we are, you are going to need to really have a look at this question of minor injuries, and I think it would be helpful for that to be picked up as an action point to be looked at a meeting of IJB, because it fits within that whole question of how we deliver primary care across the city. It's not just about GP practices, it's about the whole picture. My point, and obviously there's a lot of things being done that you've outlined, and I wouldn't take fault with any of them, but it is clearly an intractable problem. And I know, this is having a real impact on acute services. And with the other hats that some of us wear, we know that people not being discharged out of that setting into the community setting soon enough is creating pressures on the system. It's leaving patients in the wrong place. They're in a place where they don't get the care and attention. They're getting different care and attention from that which they're really needing. And and to be blunt, it also has a cost implication for that part of the healthcare system, because by definition a delayed discharge bed is an unbudgeted bed. So it is creating lots of issues in other parts of the system. So that's why it's so important that we look at those. And certainly one of the things in the paper that accompanied the presentation, you were talking about at the moment, complex and standard delays for Dundee is a total of 55, and the target is 50 by the end of November. Sorry, by the end of October. My question is, well, it's threefold really. First, is that ambitious enough? I'm not sure that it is. What's the target for the next month and the month after that? And how are we as an IJB going to track that? So that's really my question about doing everything that we possibly can on this side of the fence to deal with the issues.
So that target relates to our delay matrix, with the aim that we'll be in amber by the end of October and then aiming for green by mid-December. We are close to achieving that target at the moment in relation to our non-complex 9 wells delay, and we are seeing a downward trajectory. There's another strategic briefing that I've asked to come back in December that will outline the actions we're taking, because the non-complex standard delays are largely in relation to the availability of social care. So there's an equally detailed action plan around that in terms of the work we're doing to try and improve the capacity and flow through that service that I'm intending to bring in back. And that's everything from recruitment and retention through to better processes of assessment, changing our front door model, trying to increase the actual delivery, more involvement of AHPs at the early stage to make sure that people are being optimised in their own abilities, and so on and so forth. But we're experiencing a really high level of demand for our services, and this is despite increasing our social care provision hugely by a couple of thousand hours a week over the past year.
And can I just clarify, when you're talking about amber and green, what are the numbers in terms of delayed discharges?
Can I go back and check that? It depends, because there's targets set around that. It's actually on the slide, the matrix for that. There's targets around our complex and our non-complex delays, and there's targets around those in 9 wells and those in the wider system. So I would probably be completely winging it to give you the numbers right now, but I can come back to you with the matrix.
Don't wait. And if the answer is in the slides, that's fine. I can read it. I suppose my only remaining question are these targets that have been agreed with colleagues at NHS Tayside?
Yes, they're Tayside wide.
Yeah. Okay. Thank you.
Okay, thank you. Thank you for that, Donald. Thank you for your response, Jenny. I suppose the only issue really is before I bring in others, is the issue of social care capacity. If you haven't got additional capacity in social care providers, how do you stimulate that? Obviously pay is a big issue. It's a UK issue, so that we don't pay enough people. People leave because they can get a job in hospitality that earns more money than providing caring responsibilities. So I can understand it is an issue, and I don't know the answer to it, but I can see that we're struggling a bit with it. Anyway, I'm going to...
Can I maybe come back on
Yeah.
that just very quickly? We are starting to see a bit of an impact of the work that we have been doing, and I think the pay element, and we did obviously increase the hourly rates, part of it. I think the more significant bit is in how you make the job attractive as a career option. So the fair work stuff that we did, that we brought to an IJB, I think maybe about 6 months ago, is probably having a bigger impact, and moving more towards that care coordination model, where instead of having people that are working for a couple of hours then not paid in the gap, they're paid to be on shift and really able to adjust and change the care that people need as they need it. So we are starting to see some early green shoots on that one, Pat.
That's great. That's great. Congratulations. Well done. I know many councils and authorities have struggled with this. And actually, it's interesting because I was out the other day, and they've got posters up where I live in the bus shelters saying, you know, could you care? Would you be one of the special people who could provide caring response? And it's a young girl in the advert, you know, and she's gay. So there is this kind of you know, cross the country approach to try and making caring a profession for people, and it'll need a lot more development and a lot more money, I suspect, before we get there. I've got Sarah, and then I've got David Shaw, and I've got James Cotton. That's just the sequence they're coming up, but I'm happy to take anyone. And I don't know, is that a legacy hand, Dorothy, or are you wanting to come back in as well?
Oh, yes, sorry, legacy hand, sorry.
No problem. Okay, so can I ask Sarah? Good morning, Sarah.
Good morning, Pat. Thank you. Jenny, thanks very much for your presentation. Recognising how complex the system is around unscheduled and scheduled care, having lived and breathed it like you have for many years. So thank you very much for your presentation. Basically, a couple of observations. One is I really welcome the transparency of the management of delayed information coming through the health and social care partnerships and through the IJBs, and think it's really helpful to have that transparency to allow the total narrative to be understood about the breadth and depth of work that is going on within the health and social care partnership to address delayed discharges. I'm thinking with my head in a preventative mode and wondering around work that we may be doing or may need to consider around management of expectations of people when coming into hospital. So discharge, thinking about returning home, for me is a bit like a concept when you book into a hotel, if I can be so bold. You know that you have to get out of your room by 11 o'clock the next day. Obviously, people are unwell. We can't be as rigid as that, but actually the premise is going home is the norm, and therefore managing people's expectations about returning home with something hugely different to what their health need assessment demonstrated prior to coming in is of interest to me in terms of risk appetite. So the number of care packages and the volume of them and what people get, I'm just wondering how we're managing that risk as we focus a lot on the risks to patient safety when in a hospital bed by remaining there when it's unnecessary and actually then becomes a risk to their health and well-being by remaining in an acute hospital site. So my question's more around, is there anything we're doing upstream to help manage expectation around discharge planning so that we're not always just thinking about the outputs to address that and risk appetite associated with that? Thanks, Julie.
Yeah, I think that's local and national. So we've obviously published our eligibility criteria and have quite a lot of conversations with people about what we can and can't do. And there was a discussion about that nationally, about kind of sharing that risk and something coming out jointly between the Cabinet Secretary and COSLA to help take some of the weight of that. I think it is really hugely important, though, that we manage expectations and we're clear about what we can and can't deliver. Ultimately, when we don't have all the resources we would need, the best thing we can do is use them fairly.
Okay.
Thank you.
Thank you for your question, Sarah, and thank you, Jenny. I've got David Shaw and James Cotton. I'll just take them in that order, if I may. Good morning, David.
Morning. It's just a couple of comments with regards to minor injury units. we've never had an MIU in Dundee. I think the closest thing that we had was Dundee Royal Infirmary, and that is a great place to move to if you want a flat in a city centre location, but it's not providing any ED services anytime soon. ED have made significant changes with their flow navigation hub that allows video consulting and phone consulting for patients to keep them out of the department if they don't need to be there, and also to ensure that they have an appointment slot rather than just attending the ED clinic. So I would like to highlight that the flow navigation work that's currently underway has been very useful in reducing unnecessary footprint within the department. There is obviously the ability for us to define a local MIU provision that takes place within Angus and Perth, but we would need to be very clear as to what the purpose of such an institution was, what was safe to be within it, where the staffing was to come from, what premises requirements needed to be there. So I think it would be a major project to undertake. Not to say that we shouldn't do such a thing, but certainly we need to do that in parallel with ensuring that we have good efficiency for expert opinion for people within the community. And I think the Flow Nav has certainly made strides in that direction.
Okay, thanks, David. Thank you for your comments. Duly noted. I've got James Cotton.
Thanks, and it's interesting to hear what David said, and thank you, Chair. It was around the minor injuries, and then maybe a question around delays. So I guess it's a common observation and a comment. So through our 9 roles at ED, we are seeing an increasing presentation of patients, and what is explaining that is an increasing presentation of minor injury cases through our ED. And the observation is that has an impact on the total volume of presentations, but also our ability to flow patients through the system efficiently and effectively. So I think it's a really important point the board has picked up on in terms of the provision in Dundee, because the model of care in Angus and P&K is a different model. So I guess that's just a comment and observation. I do recognise David's point, though, that establishing a minor injuries unit is a complex and big piece of work and has a workforce and resource allocation to it. So but I do welcome that conversation. The second one, Jenny, I recognise this isn't really directed at you specifically, but you did present extremely well, and I recognise the phenomenal amount of work that has gone on with delayed discharges. When we talk about delayed discharges, we quite often get fixed in the number and the time that patients and people are waiting. And I suppose my question really, Jenny, is how do we understand and capture the risk to the people that are delayed, because these are patients within our healthcare system that no longer need to be in a acute healthcare environment, and therefore we're posing a risk to those individuals, and are we capturing and measure that? And the second question is, are we capturing and measuring the secondary risk? Because when we have patients within our acute beds, within my acute beds, that no longer need to be there, I find it difficult to bring my elective cases in to treat those as well. So there's a secondary risk to that. Donald touched on the financial risk, which it was a separate one, but also very important. So it's really just trying to understand this and look through this through a risk lens rather than just a numbers lens and a performance lens.
Yeah, and we've absolutely seen that in that when we start having increases in the number of people delayed, the outcomes for that person can tend to be poorer, and we start seeing increasing numbers of people going into care homes that maybe could have managed at home if they hadn't been as long in hospital. So I think we're very acutely aware of the risks that we're experiencing at the moment, and the need to reduce particularly our non-complex delays and get people home as soon as possible.
I guess my question for board is how can we measure and see that risk? How do we understand that the individual person risk is around the number or financial risk? And I don't know if I have an answer to that, and I'm sure you don't off the top of your head, Jenny, but I suppose it's just to pose a question to think about.
Okay, are there any other questions or points? Anyone? Dave, you've got your hand up.
Yeah, thanks, Pat. I suppose for me, it's just a kind of bit of clarification in terms of the kind of the board's kind of positioning in terms of going back to the minor injuries unit, because as you say, that's been a couple of times it's been kind of raised as an issue. So are the boards looking for us to bring back some form of sort of business case around the establishment of a minor injuries unit in the city? Just what is that? What the kind of board's seeking?
Well, I'll let Donald come in first now. I've got some thoughts on it. Donald, let you speak first.
Yeah, thanks, Pat. And good question, Dave. I don't know that. I mean, I certainly, as a member of the board for now anyway, don't feel that I don't know enough about the pros and cons of minor injuries units versus taking people into the acute setting, even to set people doing a lot of work in a business case. I think, it probably needs to be taken step by step. And I think a useful first step would be just that pros and cons. I mean, David a little while ago touched on some of the pros and cons. I think, the fact that we haven't had one in the past is not a good reason for not having one now. But I think it just needs to be teased out, and maybe from that initial pros and cons discussion will become a clearer view of whether this is something the board wants progressed.
Thanks. Thank you, Donald. I would have thought that this discussion should be taking place as part of the unscheduled care network with your colleagues in the acute sector as well. I mean, the minor injury issue is historically not been something you've had in Dundee. And as Donald says, that doesn't mean to say we shouldn't be considering it now. There is lots of published evidence that by and large, if you look at the triage categories of patients that present in A&E departments, it can be as much as 50 to 60% of people are in triage category 4 and 5, right? Some of that data is a little bit historic because NHS 24 has leveled some of that out. The availability of support and advice in pharmacies has changed some of that. And as Jenny has said in her presentation, there's lots of online services now where we can provide support through the ambulance service, through the various services that we provide, so that might not be quite the case now. But it would be interesting to look at the data to see how many patients who present at 9 Wells could have been, or PRI or whatever it is, could have been managed through a minor injuries unit. And you can do that through the case mix. You can look at saying, well, what did people present with? Oh, they presented with a sprained wrist. So they had a sprained wrist and they took themselves off to 9 Wells. I think possibly mainly because all the buses go there. But they could have been managed in a minor injuries unit. So it would be useful. I always like the data. The numbers are the numbers and they don't lie. So I always like to know what percentage of those patients, and if you would know then, is it something worth doing, something worth taking forward, because it's a lot of work to set up a service like that. And if it turned out that only 15% of patients were presenting with these kind of minor, triage categories 4 and 5, then it wouldn't probably be worth it. So it'd have to be a big enough scaled up operation to make it worth running, because they by and large run from 9 to 9. They're staffed by advanced nurse practitioners. There's models for them all over. There's one 5 minutes down the road from me. When I fell and gashed my leg on a tree when I was out with my dogs, I didn't go to the A&E in South Glasgow Hospital because I'd been there for a long time. I went to minor injuries and they stitched it and they sorted it and whatever and sent me home. So that's the kind of thing, and they have usually a prescribed list of maybe 25 sort of conditions, if you like, that they treat, and they take all the minor stuff away. They tend to work big in big city conurbations where A&E departments are overwhelmed, and it might be that we're getting to that point. So I think the first protocol, would be to discuss with your unscheduled care network colleagues and the Lorna Wiggins type people of this world who you work very closely with. But I mean, the unscheduled care pathway is a health and social care partnership responsibility. So we have a lot of authority in that respect. That would be my suggestion. I don't know if colleagues would agree with that. I've got Annie waiting to come in. Annie?
Well, to my mind, there's a model which is not just minor injuries, it's minor injuries and minor illness. Again, you know, living in West Fife, I've been to Queen Margaret, been prescribed antibiotics. So there's a range of conditions that can be managed out with the acute A&E environment. So it's just worth throwing that in as well. It's not just minor injuries that that can be dealt with.
Yeah, I think there's all sorts of possibilities, because then there's issues about children. Do you take children to minor injuries, or are they not suitable for minor? You know, you'll find that there are different models in different parts of the country. So I think it's certainly worth looking at. It's certainly worth keeping it on our radar and bringing it back at subsequent meetings if everyone's in agreement to that. Okay, so thank you for that, Jenny. You did a great job this morning answering all our questions, so well done, and we're always grateful for your input to this meeting. Thank you. Moving on, Willie.
Yeah, thanks very much, Chair. With that report and presentation having been noted, it takes you on to item 9, Dundee and Angus Stroke Rehabilitation Pathway Review. That's at page 21 of your agendas.
Okay, who's presenting that?
Me, if I can get the right buttons. Sorry, I'm earning my money today. Yeah, this is an update. Probably get through it a lot quicker. So this is an update report. You'll remember we brought the stroke report originally, I think maybe about 6, 7, 8 months ago, proposing that we run a joint inpatient rehab facility across Dundee and Angus, and this is just an update report about the progress to date with that, and we're intending to bring back a paper about our community modelling in February. So we've now got the unit up and running. It's working well. We've got the financial modelling around the inpatient service. We're through all the transition process in Angus, and it's really just to note the progress on that. Happy to answer any questions.
Yeah, thanks, Jenny. Thanks for that. Any questions? I've got Donald and I think I've got Dorothy here.
Yep, thanks. Just a quick one, Jenny. I mean, in the paper it mentions that, you know, there's a table 1 shows resources released, i.e. people. So, you know, 9.5 people. I'm just curious what happened to these people. Were they redeployed elsewhere in the organisation?
They predominantly ended up working in the services up in Angus. We didn't have people choosing to come to Dundee. So what we've ended up with is a financial resource release in Dundee rather than the natural bodies.
Okay.
Unfortunately.
Yeah.
We were hopeful of more, but it did not materialise.
Right. Okay, and I've got Dorothy.
Yes, thank you, Jenny. On risk 2, I'm looking at the risk section 6, risk 2. Number of patients presenting with stroke increases of around 20%, which is reflective of data across Scotland. I find that quite concerning, or are the health professionals not particularly concerned about that? Should we be concerned about that? Why is it happening?
I am probably not the person to answer the why it's been happening. Having spoken to Matt Lambert and people that are more involved in stroke, I don't think we fully understand why, possibly an increase in prevalence due to COVID. But yes, concerning. I think though, however, on the positive side of that, the work that's been done to improve the stroke pathway through with thrombectomy and thrombolysis up in 9 Wells, we're seeing probably a different population, so more people are going home straight after having their stroke, but the ones that are coming over to RVH, the main impact is that they appear to be becoming more dependent.
Thanks, Jenny. I mean, the Royal College of Physicians do a stroke audit. I think I'm not sure if it's every year or every 4 years. My medical colleagues on the call would probably be more up to date on that, but the RCP do an audit, which is very detailed, and they publish a lot of they highlight a lot of the issues in the management of stroke. I think we are one of the leading units in Scotland on the thrombectomy front, and that's taken a considerable amount of investment. and you know, required upgrading of theatres and all sorts of capital implications of that in order to be able to provide a theatre environment suitable for thrombectomy. It's such a sophisticated procedure. But essentially, I think that improves outcomes and reduces mortality, and as Jenny says, gets people home and back into normal life. We generally get very, very good feedback on our stroke services. If you know, people in clinical governance and Annie's on this committee will see that, you know, we get a lot of positive feedback. In fact, I had a friend recently who lives in Bridge of Allen, but was up in Perth, took a stroke, was rushed to PRI, and then straight into Ninewells and went through thrombectomy, a youngish guy. And he's done amazingly well. You would almost not know he'd ever had a stroke now. And I know he's written to the board to say what an amazing service it was. And his wife is a retired director of nursing, so I think they were very impressed by what we provided. So I think we're fortunate in having a very good stroke team. I think that's an important issue for us. Do you want to come back?
Please. I remain concerned, and I wondered if someone could signpost me to where I might find some additional information on this. What is a huge increase in people presenting? Can anyone do that?
I will ask Matt Lambert if he can.
Yeah. Sorry, Jenny.
Might that not be a public health? Sorry, Jenny, a public health type. Maybe Emma and her team might have some information about the incidence of stroke. I don't know, Pat.
Emma's just appeared as if by magic. Emma.
Yeah, I'm very happy to look into that. I'm also very aware that there's work happening with Public Health Scotland looking into cardiovascular disease in general. So I'm happy to take that away and work with the team to understand both the Tayside and Scotland.
So can we put Dorothy, can we link to yourself with Dorothy on when you find the answers to these questions? I mean, it might be useful to circulate it to the whole board, but I know Dorothy has a specific interest in that. Would that be okay, Dorothy? Yeah. Okay, thank you so much, Emma. That's very helpful. Thank you for your intervention. Okay, has Sarah still got her hand up? Did you want to come in, Sarah?
Yes, thank you, Chair. Thanks, Jenny, for your paper. It's good to see the progress being made to the shift from a hospital model to community model, and you know, that multidisciplinary approach through really proactive use of allied health professions as part of the recovery. My question this morning was actually similar in part to Dorothy's, and again thinking prevention wise about the concern in raise of numbers, and noting Emma's offer to assist with that. I was also quite thoughtful around impact of poverty on diet and exercise choices, you know, in terms of lifestyles, and wondering if this is a trajectory that's maybe going to continue for a while when people may not make as healthy choices as they might have done. And one of the biggest impacts, as we know, of prevention of stroke is healthy lifestyles through diet and exercise in particular. So just really, as Emma's doing any explorations, just interested to keep a closer eye on those trajectories, because if this continues to increase, then yeah, it's of significant concern.
Thank you, Sarah, and thank you for raising it, Dorothy, for picking up on it. It's really helpful, and thank you for everyone's comments and interventions here. Okay, I think we've just got to note that paper, have we?
Yes, thanks very much, Chair. Yeah, that's just for noting.
For noting, okay, but there's a few wee actions have come out of that, so that's helpful. So keep us right, Willie. Where did we have the comfort break in? 11:30, was it?
Yes, certainly. If you feel you would wish to break at 11:30, that'd be fine. Or be guided by yourselves here.
Yeah. Can we keep going till 11:30? Is that okay with everyone? Yeah. Okay, right. Keep us on track, Willie. Okay, thanks. Item 10 then before we use the deep primary care improvement plan update. Okay. And who's presenting that? Is that David Shaw?
It's myself, Pat, that's going to start, and then I'll pass over to David if that's okay.
Yeah, sure, Shona. Yep, great. Nice to see you.
Thank you. Thank you. I think I do know most people, but just in case there's anybody new to the committee, I'm Shona Hyman. I'm the manager for primary care in Dundee, and you'll realise from the paper that this is an update on something that we've been reporting on since the advent of the current version of the JMS contract in 2018. So we've been bringing regular updates, and it's good to be here this year and have moved on a little bit from the impact that COVID had over the last couple of years, and hopefully the appendix, which is quite detailed in terms of what we've managed to deliver over the last year and the plans for the year that we're currently in, highlight some key areas of progress. Linking back to what Jenny was describing around delayed discharges and urgent care, obviously the majority of urgent care is actually delivered by general practice, and developing a workforce that links with that is very much key, and that sits alongside other urgent care work that Jenny's team's doing. So there's been an increased number of advanced practitioners that we've been developing, so we're starting to see some shifts in terms of the developing and expanding capacity to work at advanced practice level across the system. And there's a lot of work around developing that and ensuring that we're integrated as much as we can be in relation to our pathways. Care and treatment services is another area where we've seen a significant shift this year. We didn't quite get, as you'll note in the recommendations, to be able to fully implement the commitments for the MOU, which were due to be in place by March. But again, we've seen an increased shift in quite a significant number of areas, which is having a positive impact. One of the things that we've had a lot of complaints about over the last couple of years is things like people not being able to get their ear syringed when they felt that they needed it, and that's shifted. So there's a number of new and developing services within that, and that particular team had around 5,000 contacts in September for appointments. So we're beginning to see increasing shifts in the work from our general practice core teams. We've had a gap in terms of sort of the evaluation and the impact that this is having for people, but we've had a little bit more capacity to do that. So there's some ongoing work, and we've got draft reports that we're starting to be able to pull together in terms of feedback, both from general practice colleagues in particular and the perceived impact that the developing services have had, and more importantly from people accessing services. And they're really, really important because they continue to highlight a number of areas where we were aware we needed to continue to develop services, but where there's ongoing challenges around how to get pathways that are streamlined as best we can for people. It's been a little bit of a dip in terms of our mental health delivery. We had a significant number of psychologists that left the PAMS part of the service for a range of reasons, particularly around development opportunities for them. So the model's been changed so that there's more of a mental health nursing component to that team. And again, we've been really positive in terms of the recruitment, and they've now recruited to all posts. So we're optimistic by January all practices will have that mental health link in place. So again, we've seen some dips, but they are progressing, and you'll note that Table 2 in particular has highlighted the increasing spend on most of the areas, but mental health is one of the areas that has dropped a little bit this year. The Scottish Government allocation for this is significant, as you'll be aware. We've had underspends on an ongoing basis because of the challenges that we've had, particularly around our workforce recruitment, and we've been highlighting that in the risk reporting that we've done every year since the beginning of the reporting. The Scottish Government has changed the funding model this year, so that we'll use reserves first, and then we'll be given the sort of additional funding from the Scottish Government in relation to the allocation, and that does have an impact on the delivery, particularly looking forward to next year, as well as how we're utilising our funding this year. We continue to have workforce and premises challenges. These are key risks for us. So it's really helpful that we've got the GP premises strategy that Julia's going to present on as the next item that starts to progress that agenda in a more planned, longer term way. But in the interim, we're looking at how we best deal with the really acute pressures that we have around our premises, which is a Dundee issue more so than in Angus and Perth and Kinross, and does create limitations for us in terms of some of our staffing. So in some teams we've been able to recruit staff, but we find it very challenging to actually find space to put people to see patients. There wasn't any other particular areas that I was going to highlight, other than sort of to say thank you to the teams, because obviously I don't manage any of the teams. My roles in terms of supporting and coordinating this, and there's been a huge amount of work to try to catch up and get things closer to where we'd wanted to be. We aren't there yet. The challenges for primary care demand is huge, as it is across the whole of the system, and obviously the more that we can get in place around our wider primary care teams is absolutely critical to help in that capacity, to ensure that people are seeing the right person at the right time, and that's really important for us. I know David wanted to add a couple of things to what I was going to say. Thank you.
Thanks, Shona. We'll let David add to that.
Thanks very much. I guess really what I just want to say is that there's a reason why we have this Primary Care Improvement Fund, and its original purpose was to try and stabilise general practice. I think within Ken's opening and closing remarks, he highlighted that unfortunately we'd had one GP practice close. There are a number of others that remain in difficulty. We have a number with closed lists around about the town. And I do think we are now at the point where we are getting a meaningful output from our Primary Care Improvement Fund services. It perhaps isn't everything that we would wish, and I would certainly note Shona's concerns about the constraints on both recruitment and premises, which have interfered with our rollout. But I would also want to say that our ambition is to do more than just stabilise general practice. It is to provide better care for patients, and the specific funding streams are funding things which are actively useful for patients and do improve the quality of care they receive. So, for example, the wound care that you receive down at the Care and Treatment Centre means that we have people who are able to follow up over time complex wounds and develop skills in healing these more rapidly than if they were perhaps getting care elsewhere. Our nursing home teams help to support better care within those sorts of residential environments for our most frail and vulnerable patients. Our rapid access to mental health support helps people in crisis. Our rapid access to physiotherapy helps to keep people working who want to do that and are needing that bit of additional assistance, and helps to resolve people's musculoskeletal problems more rapidly. So I think we are doing something that's incredibly meaningful. We have an ambition to do this better, and it is always frustrating when we can't go as hard and as fast as we'd like to on this. I'd certainly commend the work that is being done by all the various different teams around about Dundee. That's just what I wanted to say.
Thank you, David. I think that's really helpful, and to hear it from someone who's working in the field, who's actually providing and leading primary care. It's obviously so much work going on there. Okay, do we have questions? I've got Dorothy first of all. I don't know if anyone else has got questions for either David or Shona on this paper. Dorothy?
Thank you. I'm looking at is it an action plan? Yes, the appendix anyway. Page 52 in my bundle, number 8. Premises, infrastructure and IT systems. I'm not sure in the final column, the end column, I'm not sure what the actual risk is here. I can't understand, I haven't been able to identify what the actual risk is from the wording, and maybe I just don't understand it. If someone could tell me what the actual risk is here. I have another query on further on in the report. Page 55, number 9, workforce planning and development. Practice nurses continue to feel uncertain about the future of their role in some practices. I'd like to know why that is, please.
Okay, I think Shona's going to respond. I don't think the issue about practice nurses is unusual, but anyway, I think they've been insecure and unsure about their role for some time. But Shona, I'll let you answer Dorothy's query.
So the column's not specifically around risks. We do have a new IT system that's coming into general practice. We use a slightly different version for most of our services that allows them to work across practices. So it doesn't matter if you're in David's practice, you can see people from any practice in Dundee, so we use the system slightly differently. So there's just a degree of complexity around introducing that. I'm not sure if that was the key part. Certainly in relation to space, we work really hard across a number of teams, including our colleagues in the NHS Tayside property team. Obviously, property and premises is devolved and it's not ours. So it's challenging because they've got a number of competing demands. Do you want me to pause and see if that answers your question before I move on to the practice nurse one?
It's helpful. It's helpful. Thank you, because from what's written there, I didn't understand what you've just said from what's written there, but now I understand. I was looking, what is the actual risk? But you've explained. It's just how it's written.
Yeah.
Thank you. That was helpful.
Yep. I guess part of the risk, particularly around the posts, is around developing a capacity to. So there's a significant risk around GP premises for GPs. David talked about this a bit when we had the IG development event a couple of months ago, but I don't think you were able to make that, Dorothy. But so leases and loans is a wider issue, and that links through, and we'll maybe pick that up under the premises strategy, which is next. In relation to the practice nursing, so obviously key elements of work that practice nurses have done to a hugely skilled degree for many years is now moving from them to care and treatment services. Now, some staff have moved across to care and treatment services teams, but for some nurses, I think they feel that things that they enjoyed within their role are no longer necessarily part of their role. Now, there's huge opportunities, because they are absolutely a skilled workforce, to look at sort of further development within the role and how they support the team within core general practice, particularly working at practitioner and nurse practitioner levels. So I think it's the change to roles, and if you've always done travel vaccines and really enjoyed it and now someone else is doing that, that's not part of your role. I think people are feeling a loss of something they enjoyed, and particularly, as I said, because they're skilled. But there are opportunities, and practice nurses are seen as absolutely key to the core general practice workforce going forward, as well as opportunities that they may have had to take those skills to the care and treatment team, and that team have really benefited from the practice nurses that have moved to that team.
Could I just ask for some reassurance that there's engagement going on with practice nurses as a group? To kind of
so there's two things. So relatively recently, about a year ago, there was a chief nurse for primary care and care homes appointed. So Sandra Gourley is in that post and is linking really closely with practice nurses and has regular meetings. And in fact, through primary care improvement funding, we've also recently appointed across Tayside a general practice lead nurse, because we've had a gap in Tayside around that for some time. So Maureen currently is contacting all of the practices across Tayside, particularly to a view at looking at how to support practice nurses to have a much clearer understanding of some of the issues and challenges as they perceive them, and to look at how we support that going forward, including things like models of supervision and support.
Thank you.
Okay, thank you for that, Shona. I think David wants to come back in as well. And
yeah,
then I've got sorry.
Just a quick additional comment with regard to practice nurses. So as Shona outlines, there have been a regular series of Zoom meetings with GP practice nurses to, I guess, discuss changes and also opportunities. And I think there have never been more opportunities for primary care nurses. There are more locations to work from. There are higher levels of practice. So I think it is very much change rather than a direct threat to employment. But change is in and of itself sometimes threatening. We are very committed to trying to retain our primary care nursing workforce. It is integral to so many different strands, not just within general practices, but within the partnership and within wider NHS Tayside. I view this more as a good news thing, but sometimes good news comes with concern because change is concerning.
Okay, thank you for that. Yeah, change is difficult, but I think there's exciting career development for practice nurses, certainly, if that's what they're interested in. Martin Sloan.
Thanks, Chair. Just a quick point. I welcome the report in its entirety. It's a good report, but I must temper that by saying the language used in the report and some of the styling makes it quite difficult to read and quite difficult to decipher. For example, the use of mechanisms is quite extensive in the report, and you're having to move backwards and forwards from the report to try to decipher what they actually mean. So I would suggest that in future we have a really look at how the styling of reports of this nature comes to the board, because as I say, we have a lot of our stuff is now put in the public domain, so therefore if a member of the public tries to read this, they would find it somewhat difficult unless they come from a health background or a social care background. So I just want to temper that it is a good report, but it just needs to be a little tweaks in the styling and the wording.
Shona, do you want to respond to that?
Yeah, I absolutely accept that, Martin. It's a good point. I think we're trying to use one document to deal with everything. So we use this as a dynamic document for the team as well as using it as a public facing document, but I accept the language isn't ideal for that. I guess it's because we wanted to share the detail and the complexity, but we maybe need to look at how we have maybe a summarised version for public.
Yeah, put it online or whatever. Yeah. I take it you were just going to agree with that, Dorothy, were you?
Yes, could I just say this? I've got a note to raise this. I was going to raise it at the end of the meeting. I'm glad Martin's raised it. There are a number of reports for today's meetings in a similar vein where, you know, the use of initials for groups and things like that. There's a word for that. Can't remember what it is. The language that's used is probably familiar to health professionals, but some of us on this group are not health professionals. And I found this particular set of reports for today's meeting really challenging, with the exception, I have to say, by a couple further on down the agenda, written, I think, by Catherine Sharp. And I think maybe the difference there is that these reports are written by health professionals, and as a non-health professional, I find that very difficult, the language that is used. I think it's quite important because input, you know, from local councillors or service users, you know, is vital on a board like this, and we need to understand. I did find these reports very challenging this time.
We have duly noted your comments, Dorothy, and as ever, we take that on board. Thank you for the points you've raised. If there's nobody else, no one else with their hand up, what we required to do with this, Willie? Is it assurance? Is it for noting? Do we need to take actions? We need to formally approve the plan, don't we?
Yeah, thanks very much, Chair. There are a number of recommendations there through from 2.1 to 2.7. A number of them are for noting. If you wish, I'll just read them out. 2.1 is noting the progress to implement the Dundee Primary Care Improvement Plan, which is attached to Appendix 1, and the key achievements as described in 4.3.3 of the report. 2.2, approve the proposed actions for the Dundee Health and Social Care Partnership for 2022-2023, as described in Appendix 1, and notes the proposed allocation of funding as detailed in Section 3 of the report. 2.3 notes the updated funding position from Scottish Government for 2022-2023 and intended use of reserves during 2022-2023 as detailed in Section 3. 2.4 notes that aspects of the plan were not fully implemented by March 2022 and that practices will receive transitionary payments for services they are still delivering. 2.5 instructs the Chief Officer to issue the directions to NHS Tayside to implement the specific actions relevant to them in Appendix 1. 2.6 notes the previous agreement to delegate the monitoring of the Dundee allocation of the Primary Care Improvement Fund as noted in Section 4.2 of the report. And finally, instructs the Chief Officer to provide a further report on progress made in the forthcoming year of delivering the Dundee Primary Care Improvement Plan to a future IJB.
Thank you for that, Willie. Just before we approve it, which I assume we will, I'm going to ask David about the funding. You know, because we have a position in terms of reserves. Do you feel, David, that, and I include Shona in this, and I see Dave Berry's come on camera. The minute I mentioned money, he was quick as a whip. So do you feel, David, that we have got enough money in your system to do? I know you can always use more money, but have we got enough in the system to take this plan forward? And do you think there are other issues that you could be addressing if you had additional funding?
I think the issue has been that if we fully delivered on our ambitions, then there's not enough money. We have been limited by an ability to recruit and an ability to put people into the places in which they can work from. So we are guilty of underspending, but a realised budget would put us into an overspend position. And certainly we could do more than just this set of things. So there is additional work within primary care that we could do that isn't within PCIF. So could I spend more money usefully doing something that was good for patients and which was a good use of IJB resource? Yes, I could. And it would be separate and additional to that which is in PCIF. But I'm struggling to spend it just now because of these constraints. We do have an absolute commitment to get it all spent, or otherwise we will lose it. And losing money from one of the more deprived areas in Scotland with the absolute amount of patient need that we got is not acceptable.
Indeed. Thank you for that, and thank you for your very great honesty in your response. Shona, I'll let you come back in, and I don't know if Dave will have a comment. Shona?
Yeah, I mean, it echoes what David said. We did do a piece of work just before COVID, looking at what we thought potentially the full cost of implementing all aspects of the GMS contract. So it's only 7 areas in theory, but they are quite big, and it's a several £1 million gap we felt to be able to implement everything. So the commitment that we had around the March 22 delivery wasn't everything within the contract. There are still other areas, and absolutely, it's like any sort of target-driven work. You focus on implementing those areas, and that's what's funded, but there are other areas where we would be able to develop care if there was other and potentially improve patient pathways. Most importantly, I think if there was additional funding, we just haven't had really the capacity to think what those key things would be to get to the stage of bringing a case for additional funding, but the opportunity to be able to do that would be helpful. And I think we do have a significant challenge for next year, which I'm sure Dave would pick up on.
Do you want to pick up, Dave, or will it come up under your financial paper?
No, because the financial paper we've got really relates to the current financial year rather than next financial year. So yeah, so I mean, as kind of David and Shona have made out, you know, we could, if we had been able to spend the money quicker, we would have done it. I know across the country there is a real concern around, you know, full implementation of the primary care improvement plan against available resources. Now we've not been at that stage yet, but it is kind of looming. It's on the horizon. If we start to look into next year, we've got a projected shortfall next year, but we'll need to kind of consider that as part of the IJB's overall budget considerations as we kind of move through the coming months to set the budget for 23-24. So so yeah, we're fine for now. I think that there has been an opportunity lost in terms of the implications of the Scottish Government's funding letter for this year, where they've utilised the reserves as part of the overall allocation, rather than letting us spend our reserves and draw down our allocation as well. So it's done for their own kind of balancing purposes, but that certainly had an effect, again, not just for us in Dundee, but across the country in terms of a number of planned initiatives that people had been kind of looking to put in place, have not been able to go ahead as part of that. So so we've certainly kind of, we're managing the position this year despite that kind of intervention by Scottish Government, but next year will be more of an issue for us.
I was really thinking more about in terms of the additional funding we've put into places. I think it was Whitfield, we put money into the 2C practice to support the GPs, additional sessions, I think it was, to look at, to help with drug and alcohol substance use. So I don't know if there's any other places like that where we could take money out the reserves and supplement the support that we can put into practices, because as you've said many times, these practices are working in very deprived areas, and any additional, I mean, I don't know what the position is on reserves. If we don't spend it, do we have to send it back? I don't think we do, but I'd like to see. I think we collectively as a board would like to see some of that money going in to support provide additional support in primary care. We want to keep everybody we've already got, and we want to attract more people. And the way to attract more people into general practice is to try and demonstrate that they've got the resources to do the difficult job that they do, because that's why people leave and they go part-time, and it's too stressful and they can't work full-time, it's too much. So if we could put more support into practices, Dave, and show that we are willing to use our reserves in that way, I think that would really, really help our situation. But I don't know what you and others think about that.
Yeah, thanks for that. So in the finance report on today's agenda, we've kind of made note that we'll bring back a number of kind of proposals to spend the IJB's reserve, or to kind of earmark IJB's reserves. So as you say, so we had the kind of additional GP hours, and we've got another one on the next item on the agenda around about kind of the premises strategy and kind of additional programme management support. So while we'll kind of pull some of that together, we will continue to kind of put forward to the IJB proposals as they arise. So it will be the management team is kind of looking at a range of areas where we think we need to kind of shore up or invest in over the short term. Bear in mind that we've got what we've got. Once it's spent, but certainly kind of utilise those reserves as effectively as we can to advance the IJB. Rather than it kind of being lost to other things.
Yeah, well, I think we'd like to see that money get into practices, so that practices feel more equipped to deal with the issues that they're facing. That is the crisis in the health service. That is the unspoken elephant in the room all the time, is the crisis in general practice, and keeping these practices and all the practice teams, keeping them on the rails and supporting them and giving them the additional resources. And when you talk to GPs, they just say they don't have enough resources to do the job and enough time to do the job that they're there to do. So I'd really like to encourage the partnership to look at the reserves and look at the financial position, and wherever possible to invest that in supporting our practices. I think that's the future for us. So thank you for that. Thank you for all the conversation. If you would just give me, I know I said I would stop at 11:30. It's just that this next item just follows on nicely, which is the premises strategy, and I don't want to kind of lose the continuity of the discussion that we've had there. If I may, so can I defer this break till the following, till we've completed that agenda item? Is that okay, Willie? We're happy with that? Willie keeps me right.
Thanks. Yeah, thanks very much. I'm happy to be guided by yourself as to when you wish to adjourn for a break.
So can we press on and do the premises strategy just while we're on a roll?
Yeah, thanks very much then, Chair. Item 11 then before is the general practice premises strategy report, page 61 of your agendas.
Okay, who's presenting that? Is that you, David?
I'm presenting it
Julia.
with help from David.
Yes, thank you. Sorry, Julia. I see
Yeah,
you. Like me, you're a little bit in the dark there.
I've put a light on as well, but that hasn't helped.
I know, it's okay. It's a pleasure to see you. Thank you for your
Thank you. I've
contribution
not met everybody before, but I'm Julia Martineau and I'm a programme manager in primary care, and I sit in Shona Hyman's team.
Great.
So as we've heard already, and you'll be aware of all of the pressures around general practice. So in response to those pressures is a need to identify solutions, and their solutions for now and also into the longer term. So this GP premises strategy is really the first step in us trying to identify the solutions, and it forms part of a wider Dundee DH&SCP premises strategy that is coming to you. So in the strategy that we've got today, we've got 3 recommendations. We'd like you to note and approve the strategy and agree that we provide annual progress reports. And as Dave Berry mentioned, to enable us to move some of this work at pace, which is what we need to do, we're looking for approval for £150,000 of funding that comes from reserves for a premises programme manager who will support this work over the next couple of years. So I'll just sort of walk you through the strategy, the sort of highlights, if you like. So we asked ourselves 3 questions. So the first question was, where are we now? And this part covers where the practices are located, the changes that we've seen to general practices in Dundee over the recent years, the closures, the list sizes, and the new ways of working with digital consultations and such like. We've also got in there the results of a practice survey. We had 23 practices, so all of them came back to us, and you'll see in there the challenges that they have told us about: leases, recruitment and retention of workforce, and lack of space, which then impacts on the ability for them to offer services and deliver the projects, including those under the primary care improvement programme. And it also covers things about the Dundee population in terms of age and ethnicity, the spread across the city, the long-term health conditions, deaths, death deprivation, and that sort of thing. So that's what we looked at on that first question. The second question we asked ourselves, well, where is it that we're wanting to be? Where are we trying to get to? And to determine that, we looked across the relevant documents. So we looked nationally at things like the National Clinical Strategy for Scotland, and obviously the GMS contract. Then we looked at Tayside, the Tayside-wide strategic plan as an example. And we looked at Dundee, for example, the city plan. And what you see when you look across all of these documents is a sort of shared ambition, and it's a move towards community sort of centred services. So this strategy obviously takes account of the need to align with the IJB's priority areas as well: the health inequality, the early intervention and prevention, the localities and engaging with communities, and the models of support and care. Our third question was to ask, how do we get there? And here what we were trying to do was to focus energy and resource so that we can move forwards. And we identified 4 criteria, and they're at 4.41 of the cover paper. And they are a community-focused model for the delivery of health and social care, premises that are of good quality and are fit for purpose, sustainable general practice service, and appropriate geographical coverage across Dundee City. And then we took that criteria and we used that to guide us in setting out some recommendations. So we've got 13 recommendations in all. And then from that, we've distilled out our activities, and we've tried to look at what are our immediate priorities. So in terms of those, our actions, we think, is to link this back to the previous paper that we had from Shona and look at the barriers, and to ensure that we get progress of these deliverables by the deadlines that we need, one of which is looming on the 31st of March. The second action we think is around leases. So the National Code of Practice for GP Premises 2018 recommends that general practice moves towards a service model that doesn't require the GPs to own their own premises. So NHS Tayside would then assume the responsibility for those leases. So what we need is to have an agreed process around the risk, the clinical need and the functionality about those moves, and focus on the leases that are due to expire. And the third action is to have a programme of work so we can see what's coming, so we can see what we need to do in terms of tasks and timelines. And the fourth action for us is an equality impact assessment to look at what we're doing, and that will include a patient survey. So to go out to the patients or the citizens of Dundee and to gather their views on premises. So I think as we close with this, I think it's around members looking at the criteria that we set at 4.41 and saying, does that seem reasonable, broad brush criteria for us to work to? And then, you know, back to the recommendations that we've made in the report. Can I check in with David Shaw, please? Have I covered everything, David?
Yeah, I think that's the big things. I'll be horrible and come in and do the bit at the end, if that's okay. Premises are really, really difficult for me because I guess the expectation is that NHS Tayside provides premises to partnerships and other agencies, so we don't actually own premises as an health and social care partnership. Our premises department very much sees themselves as an enabling department. So if you tell them exactly what you want, then they reckon that they'll do what they can to try and provide that. And what they look to the IJB to do is to provide a strategic direction that says exactly what it is that we want. And we aren't particularly resourced as a health and social care partnership to provide a comprehensive premises strategy. So this strategy that you see before you just now is a starter for us trying to give a strategic direction. It outlines where the patients are, where the deprivation is, where the new houses are going, where practices are in good function, where there are limitations, and it starts to ask questions about which premises we need and how those premises might change over a 20-year time span. And so this isn't a final trip to the IJB. I think this is one step in a journey. The other necessary steps are really to get a lot more specific about which premises we want to adopt, which ones are the green ones that we absolutely want to keep, which ones are the ones that, well, we have to think about whether that's the right premises, whether it needs a bit of work done to it, and whether there's the red ones, actually, we don't think this is core to Dundee. I could tell you an awful lot more about premises and my experience of them, but it's a long enough meeting just now. And I'm not sure that we've got the mental health support for you all after I unload my concerns about the area. So I'll stop just now and give time for other people to ask questions.
Thank you, David. And thank you, Julia, for taking us through the paper. It was good to see the paper come to the IJB, because we've asked in the past, we've voiced our concerns. We know there are lots of issues. I've got quite a few hands up here, so I'm going to start with Donald, then I've got Siobhan, and I've got Dorothy. I think, yes, Siobhan. Sorry, Donald.
Okay, thanks, Pat, and thank you for the paper and the strategy. It's been really interesting just to read about the challenges and how you're looking to take them forward. And I certainly don't have any quibble with the priorities. I think it's more of an observation that when I looked at figure 26, which is on page 96 of the papers, the immediate impression that struck me was that most of the practices are in the wrong place for where growth is going to take place, and those few that are in the right place are already under pressure, which doesn't feel like a very good place to start from. And I just wonder what scope you have actually to be radical in the way that you think about these issues, or what are going to be the barriers to you being as radical as you might like to be, and how can we overcome these barriers?
Okay, I think it's what we need to set out is a strategic direction, and I think we can be as radical as we want to be in terms of stating what we want to do. There is no money in NHS Tayside to do any of this currently, so we would be applying essentially for central government funding, and I think what they would want us to do is to think those radical thoughts, and then to parse that with a view on what's achievable. The barriers, apart from the fact that we don't have the project management in place to do this as quickly and as comprehensively as we would want. So I mean, there's that sort of initial constraints. To do this properly requires skilled people, and this paper is part of trying to acquire that, are partly to do with how premises are currently held. So we can have direct control as an NHS over those things that the NHS owns. But the NHS doesn't own very much. More than 2/3 of our GP surgery properties are either loaned, either leased by practices from a third party, or they're owned by practices. Now, there are elements within the 2018 contract that allow NHS Tayside Board to take on an assignation, and there is a Scottish Loans programme that allows us to effectively buy out the equity in practices. So we could do something. The problem that we have is that the property department does not wish to take on any unfunded commitments to do anything. And there are significant obstacles, as many of these properties will have dilapidations and running costs associated with them, which we net costs to NHS Tayside. Now, we've had some fairly frank discussions with properties about all of this, and we felt that we don't necessarily have the answer in Dundee, in the primary care department, or indeed within properties. So we have asked to escalate this, and I understand that Gail Smith is the Chief Officer for the DH&SCP that hosts primary care. Myself, John Patterson, Stuart Lyle, and a variety of other posh people are getting around to form some form of project group to say, if we can't do it, can we ask NHS Tayside Board for a direction here that will allow this to be done? So in terms of what is stopping us, partly, I suppose, it's the constraint of not having sufficient project management people. And as I said, that's a thing that we're looking to address. Partly, it's about how properties are owned and managed. And partly, it's about reaching out to acquire the capital to do the new things that we would want to do. We probably need to disinvest from some places to invest in others. And someone is going to have to pay for that. And I think the big unseen tension in all of this is nobody particularly wants to pay for any of this. And if it sits with practices, they may close. And if it sits with partnerships or with NHS Tayside, it may not progress. So I think that's a long answer to a short question. I apologise.
No, that's helpful. Thank you. Thank you, David.
I think whatever the solution is, and I'm not sure that we're going to come up with that today. I think we need, as a board, we need to be instrumental in helping you to push it forward. We need to put our weight behind it as a board to say this has got to be sorted out. It's got to be resolved. We have to have premises that are fit for purpose. It's unfortunate Tayside has missed out on a lot of capital monies that have been allocated in other parts of the country because they didn't have a strategy and identify develop the business cases. So I think now we're kind of coming a wee bit late to the debate, but we need to move it on as quickly as we can. I've got other colleagues wishing to come in, so I've got Siobhan, I've got Dorothy, and I've got Martin. Siobhan?
It may have been a long answer, but you've kind of almost half answered mine, so that's fine. You're kind of like one step ahead. I mean, looking at the report, I found it slightly overwhelming in the sense that how do we manage this forward? And Pat, you've kind of mentioned that as well. It's about kind of pushing that, because it struck me really that what you're looking at is the changing nature of medicine and practice has completely outgrown the physicality of the buildings. I think it's almost half that are no longer fit for purpose. And I suppose that was my question, which Donald has kind of asked actually. It's like, where do we get the funding for this? Because it seems almost like that we need to start thinking about purpose-built buildings in order to accommodate a future evolving practice and change in nature of how we move into that kind of multidisciplinary practice that Lochee and Stobbswell are doing as well. My question's slightly vague then. It's like, how do we navigate this immediately to try, and I know that you've got that you know, the project management role that will clearly look at that, but where does the money come from in a longer term thinking here? Because it's clearly needing done, and as Pat said, we're kind of late to the party a wee bit here. But where do we resolve these issues? Because it sounds like there's hundreds of different issues to be resolved before we get to the point we want to get to.
So try and keep this one as a shorter answer. I think the first job is to deal with the immediate, what are the premises that we definitely wish to invest in, and try and secure those. We have a mixed bag of premises across the city. So you've got purpose-built buildings, Lochee, Maryfield, the Arthurstone Medical Centre, not that I have an interest in that, which are modern and do what they need to do. You've got ones that are definitely not so great, and you'd be thinking in any sensible 20-year scheme wouldn't be looking to do that. You've also got specific locations where something has to be done that's different. So we can't continue with a porter cabin in Invergowrie as being how patients receive care over the long term. As I said, we've got things that we need to engage with very quickly. Our lease assignations start to come due over the course of the next 2-3 years. So we absolutely need to do something about that. We need to generate, I think, probably a 20-year capital program. That will take a little bit of time and effort to do, and we have to do these things in parallel. So we won't be able to make new Dundee primary care tomorrow, but we could certainly work towards describing what our options are and start describing what for different parts of the town we might want to do. I think Donald in his question pointed out that there's an agglomeration of practices in the city centre. I'm sure that anyone who reads the Courier has read about the move of the family medical group to move to a single site in Douglas, which goes some way to addressing an absence of healthcare need in that bit between Stobbswell and Broughty Ferry, which I think is very welcome. There are other locations, such as the student practices, where there are specific problems. So I think we need to engage with different sorts of problem over different parts of the town. And that is part of the next stage. It's a part of saying, what are the options for these communities? How is it we can provide something that wraps around patients? And how is it that we can get something out of working with all those other services that are not general practice that go towards delivering maximal health? So Lochee and Whitfields have been very good examples of community-based practices, and that's exactly the right thing for certain communities. They will be slightly different for the student practices. That is a community, but it's not the same kind. And then there are perhaps different answers for those practices that deliver care over an entire city. So there will be more than one model, and there is a lot of work to do. And I'm sorry, I apologised. I should have given you a shorter answer than that.
That's okay. Thank you for your response, David. It's very helpful. Did that answer your question, Siobhan?
It does. I promise it's a very quick one. So the role that we're asked to approve, the role that we're asked to approve then is they'll come back and give us that information. Is that what you're hoping?
It's another step towards it. So as I said, I think this is a multi-step journey. And this is one task amongst several. You will get more information as a result of this.
Thank you.
Okay, Siobhan, thank you. I've got Dorothy and I've got Martin. Just how they appear on the screen, Dorothy.
Thank you. I do have one question, but before I ask it, I'd like to say this is a clear and well laid out strategy, contrary to the remarks I made earlier on in the meeting, with lots of useful information. I found it really helpful. my question relates to there are 23 practices apparently in Dundee catering for 171,000 people. Now that's in excess of the population of the city, and I see there's a table that shows, you know, how many it includes from Angus and Perth and Kinross and places like that, right? How does that work in terms of funding?
We get additional funding for our primary care improvement funding pot. That's the previous item from Angus and Perth and Kinross. General practices also receive funding based on registration. So money comes in on the basis of that. Dundee has been the natural centre for people living in South Angus and for folk along the Carse for I think a generation or more. So this is not a new provision. It has, however, been something that has put particular pressure on particular practices, as what we have seen as a result of general practice pressures, it's been a redrawing of boundaries. So we are more acutely aware of how best to serve patients who are in that penumbra around about Dundee, and realise that perhaps caring for patients in Perth and Kinross and Angus shouldn't be the absolute priority for the partnership, but it is a very important thing to do. And if the partnership is the most coherent body to deliver that care, then we should try and deliver that well and make sure we get funding for it.
Thank you.
Okay, thank you. I think Martin has a question.
Thanks, Chair. First of all, I want to say to Dr. Shaw, thank you for the report. It's an excellently written report covering a lot of the issues that are out there in that respect, and I would like to thank him personally for that. Secondly, I want to say that I know a number of the people around the table know that I'm a bit of a geek, but a lot of them don't know that I'm a geek on pretty much everything in terms of technology. And one of the issues I've noted is there's not a lot of discussion about future developments of technology within practices and how they could be implemented in in the use of future technology into the future delivery of general practice across the city. And I think that's something which I don't know if it's part of that or something that could be bolted on in a future report, but I think that's something we should look at in more depth. Specifically, I'm talking about telecare, remote monitoring of people's conditions, things like that. That's something I think we could seriously look at. But in terms of the physical premises aspect, one of the things I would like to say is it would be an interesting idea if some thinking was behind the idea of, instead of having a GP practice in one building here, there, and everywhere, we have, say, 4 or 5 super hubs where it could be 2 or 3 practices co-located in the same building, along with support with social care aspects and with various other elements brought together, so we can have essentially a set of one-stop shops where people can come in, receive their medical support, but also receive the support for other issues that they may have, housing and things like that. And that's something which we could look at as a funding partnership with Dundee City Council and others, rather than having to rely on NHS as being the sole source for the funding for these premises, and maybe expand that into a better solution. And if there is a group that's been established, and if you do want a care representative there, I'm happy to come along and bore everyone to death with the ideas of how we can implement all these sorts of programs. But I'll leave it to you. Thank you.
Thanks. We did have in Wallerstown Health Centre a collection of practices in the city centre that looked after around about 35,000 patients altogether. And I think that when that was introduced back in around about 1976, that was a real step forward in the provision of healthcare. The premises aged and practices, I think, sought an exit. And I think that tells us something a little bit about how it's important to keep our premises issues as being live. Can't do it once and then expect that it's going to be good for the next 50 years. So absolutely, I think wrapping other services around about practices is a good plan. The numbers and locations, I think that should fall out of the strategy. I am not going to go into an out-geeking competition with you, but I absolutely do believe that we need to take the best advantage of the technology that we've got. There is a slightly disappointing graph showing video consultations dropping. I'm quite a keen advocate to video consults, both in my out-of-hours work and in my in-hours work, and I try and encourage all of the trainees who have the misfortune to have me supervising them to develop their skills in video consulting as well. It's very handy, it's very useful, but there are some barriers to doing it. Our other partnership services are probably better at it than general practice. It has been very, very helpful, as I said earlier in the meeting, at our flow navigation hub. I think in terms of the premises strategy, we need to make sure that all these technologies are built in. We are working on wearable technologies, blood pressure, home monitoring, and so forth, as part of other elements of our primary care strategy. So we do try and make the most sensible use of that technology that exists to enable good healthcare. And I know Shona's been waiting for ages, so I'm going to shut up and let her come in.
If that's okay, Chair, just to add to what David said, I mean, Martin's point is really important. We have tried to reflect when we pull this draft together, the impact of technology, because absolutely it's key, and it really can change quite significantly what the physical footprint is and the type of footprint. So do you need a clinical room where you can do face-to-face consultation? Then the amount of space you need for that is very different to if you were doing a consultation by video. So it really will impact on our longer term planning, and it's important that we get that right. The community focus we've tried to pull out, and Julia had noted that that was kind of one of the key priorities. So what can be co-located and what should be co-located, and that's part of what we'll try to pull out in the survey that will go out. So some things people will find quite acceptable to travel a distance for, if it's infrequently, and most of the time they're getting their care through other routes, but other things you want really close. So if you get your bloods done through a phlebotomist every couple of weeks, you want that to be really close to you. Ideally, you want to walk within a few minutes, we think, but we need to see whether that is actually what people think. There's something about working out what needs to be very local to you and what can be co-located. And other areas will have done work, as you've highlighted both today and elsewhere, Pat, around some of that learning. So it's important that we do that, that the inequalities do add a different dynamic to a degree for us, and we are investing in some things. So Martin's point again about long-term conditions management through the Primary Care Improvement Fund, we've got a system that's coming in soon called MedLink, where people can do, if you've got an asthma condition, you can kind of almost do an online review, and then potentially you could have your consultation by video with your clinician once you've done that. So we're starting to try to sort of push and expand some of the ways that we're looking to use digital. But again, particularly given the range of age and inequalities we've got, we need to plan this really carefully, and further information as we get it through the next steps will really help to dictate that.
Okay, thank you for that, Shona. I think as a first pass, if you like, addressing some of the greatest areas of pressure, I think this is a really excellent piece of work. I think what we, as a number of people have said, I think what we need to be looking at longer term for a city with such high levels of deprivation is health and social care hubs, where we could put clusters of services together if that were possible. And you often find that things like CAMS teams and CPNs and palliative care teams, they don't have a home in the community. Therefore, they quite often gravitate into hospitals where there's premises. And I think we've got too much premises in the hospital sector and not enough premises, if you like, that are appropriate and suitable for 21st century primary and health and social care integration. And I think also my view personally is that, you know, if we had these premises help to, they're an enabler towards integration, because social work teams, and you can put home help control rooms in there, and you can really bring services together who are quite disparate at the moment. Rehab teams and stroke teams and care of the elderly, psychiatry and all of that. You can give them a home where they rub shoulders with their general practice colleagues and can chat to people and meet up, and it just provides a focus, a home for all of this to come together. David, I'll give you the last word on this.
Okay, thanks. It's just really two things. First off, absolutely, if you work with people, then you work with people. So having geographical proximity for a range of services round about the patient, I think will be really, really good for patients. The second thing is, I think someone mistakenly thanked me for writing such a clear report. It would be remiss not to say that Julia has sweated buckets getting all of this together. So thanks very much.
Thank you, Julia. I think we're all, as a committee, we're all grateful to both of you, and especially to Julia for putting this all together on paper for us. There are a number of things in the report, I think, that, Willie, just to keep me right here, that we have to agree. Is that correct?
Okay, yeah, thanks very much, Chair. Yeah, there's two recommendations there for you. There's 2.1, notes and approves the general practice premises strategy as set out in Appendix 1 of the report. Approves the release of £150,000 of funding from reserves to support the establishment of a premises programme manager post over a 22-month period, as outlined in section 4.6.5 of the report, and finally instructs the Chief Officer to bring back progress reports to the IJB on an annual basis.
I just wonder if an annual basis is going to be enough. I don't think it is, but I don't know what my colleagues think about that. I think no. So I think the first one we could agree. The second one, I'm assuming that unless you colleagues put the hand up or wave vehemently at me, that we can agree the second one, which is the funding of the programme manager. Although I think 22 weeks is probably not going to be enough for that. I think this is a big job. But that could come up for review and possibly be extended, get an extension depending on the financial situation. So do we agree that as well?
22 months, isn't it?
Yeah, 22 months, sorry, Dorothy. I don't think it's long enough, but I think this could take a long time if you're going to really start, because you're starting then to pick, put together, possible developments that will, you've got to be able to answer the exam question, what do we need in each area? And then you've got to work out. And also, if you're going to try and make it a health and social care hub where social care comes, there's a lot of interaction there with social care, with the public, stakeholder, I think that's a big job. I don't think you'll do it in 22 months, but I'm happy to agree it today on the basis that we can bring it forward. We can bring it back, rather, if everyone's okay with that. And the third thing was, I don't think annual reports are enough. I think we would at least want them biannually. Well, some of you are saying quarterly. I don't know if that's a lot of work to generate these reports. I think what we're really saying, David and Julia, is, yeah, we think this is good. We want to support you. We want the funding. We want it to support you moving forward. We don't think once a year is nearly enough focus on such an important area of our business. Sure. And I'd be happy to go for quarterly if that was not too onerous for both of you to bring back reports.
We will attempt to do the best that we can to make sure that you're kept up to date with our unnecessary progress. So I think possibly every 6 months a larger report, an interim one, we perhaps can produce in between times. I'm looking at Julia just in case she's planning on killing me for saying that.
Well, maybe something around drag status or exception reporting every kind of interim, and then the fuller kind of context every 6 months. It's just so we can help you to push it forward, isn't it, Chair?
Yes, absolutely. We want to support you. We want the committee to put its weight behind it. We want the funding. I see Ken's got his hand up. Ken, sorry.
Yeah, just to say that I'd be happy with six monthly reporting, given the number of other issues that we need to keep on top of.
Yeah,
so
I would agree with you, but I think the interim report's good because we cannot afford to lose a focus on general practice. That is what is holding, that's the linchpin to primary care. We must keep a good, strong focus on that, and we must make sure that the money is going in and that they're getting the support they need to deliver this. Because
just one other quick extra thing. I thought the report was fantastic and really clear. And what it really highlighted for me was the lack of GP premises in the east of the city. Really quite striking when you see it on the map like that. The only thing that I would like to have seen in the breakdown of all the practices and surgeries and list sizes, etc., is the number of GPs in each practice. Would have been interesting to see, unless I've missed it.
That's a different issue. That's more the workforce.
Yeah,
really.
True.
The mapping of the workforce. But I think, to try and keep a focus on this as premises, the workforce issue is so big, so complex, and so difficult. I think that takes.
Although there's lots of information in the report. It's not just about premises. It's about prevalence of conditions, medical conditions, etc. So I'm just if it wouldn't have taken too much time to add that. I don't think so. Thanks.
Right, thank you, Ken. Okay, Siobhan, I'll give you the very last word on this, and then we need to go.
Yeah, thank you. It's just literally to back up what you're saying about the kind of 6 monthly or quarterly. If it's a 22-month post, then actually we might as well make use of that and get as much information as we can within that time frame.
Yeah, so you have our wholehearted support, both of you, and we want to support you as best we can. We want to make sure that we're throwing our weight behind this as a committee. So we're grateful to all the hard work that you've done. We're grateful for Julia and all her hard work. So thank you both very much.
Thank you.
Okay, thank you. That's moving on. We can maybe have a 5-minute comfort break here.
Yes, please.
And a cup of coffee, and we'll resume at 12:25 if everyone's okay with that.
Chair, could I just check the reporting basis for this report? Is it going to be quarterly or 6 monthly?
It's going to be an exception report quarterly and a summary report or a full report every 6 months to keep a strong focus on the primary care premises issues. I think that's what we're agreeing, colleagues, isn't it? Yeah. Thanks, Willie. Thank you for keeping me right. Thanks. Okay. 5 minutes, everybody.
Okay, thanks very much. The item 12 then before is the carers delivery plan and performance framework.
Okay, who's presenting that? It's Jenny.
It's me again. Thank you, Chair. Yep, we're bringing back the delivery plan and the performance framework. So we obviously brought a Caring Dundee 2 back, and we committed at that point to bring the delivery plan and performance framework at a point in the future. So the delivery plan outlines the actions that we intend to take to meet the 4 outcomes that we'd set in a Caring Dundee, which was that carers would be involved, they'd be supported to care, supported to have a full life, and to have a life of their own. And the performance framework outlines the plans for how we'll go about measuring that and reporting on it. So we've brought back the delivery plan for noting and the performance framework for approval. And I'm aware of time, so I'm happy to answer any questions, but I'll not rattle on about it.
You're on mute, Pat.
My apologies. I've got Donald and then Ken with questions.
Thanks. I'll be very brief. Likewise, Jenny, because I mean I know I'm the one who's been banging on about this a little bit, so I'm grateful to you for bringing this forward. I'm happy with certainly with what you put forward. In terms of the performance indicators, they feel to me to be the right ones. I suppose what I would like to see is something similar to what's in the Dundee City Plan that we'll look at later on with specific numbers. So I think that would be a model to follow in terms of bringing back to the committee, but I'm certainly happy to support that now. Thank you.
Thanks, Donald, and I'll take that on board about the city plan and have a look at that.
Pat, you're still on mute.
My hand was up by accident, sorry.
Sorry, Ken. Right, okay, so I've got Martin.
Very briefly, Chair, just to say that I support this this paper. It's an excellently written paper, and hopefully it will help the carers of Dundee move forward and improve their lives overall.
Thank you, Martin. And as always, I take no credit whatsoever for the writing of any papers. That was Alison Fannin for that one.
But will you pass on our
I will
thanks
do.
and appreciation for all our hard work? Thank you, Jenny. Do we have to agree this, or are we just for noting? It's not for assurance or anything, Willie, is it?
Chair, yeah, thanks very much. There's two recommendations before you. There's one is you're noting, and then secondly, you're asked to approve the performance framework, which is Appendix 2, which outlines the proposed approach to performance management of services and sports to the carers by the IJB.
Okay, so we agree these recommendations? Yeah, everybody's happy with that? Agreed? Okay, right, thanks, Willie. Thank you.
Okay, it takes on to item 13, Dundee City Plan, page 119 of your agendas.
Yeah. Who's presenting that? Oh,
Me.
It's yourself. Good morning.
Good morning, everyone. I'll be brief again in the interest of time, and apologies, we had hoped maybe one of our community planning colleagues would be able to join this morning, and they've not been able to. So if there's things I can't answer or others can't answer, I can take that away. The report, I think, is pretty self-explanatory. The revised city plan for Dundee was approved by the Dundee Partnership in September, and at that point, they encouraged all partners to take that into their own kind of single agency governance groups for information and for endorsement. So that's really what we're doing today. Many of you will be familiar with the city plan and the structure. This time round, it's been streamlined to focus on kind of 3 vision statements. And the one with most relevance to us is the one that relates to tackling poverty and delivering fairness. And the contents of the plan, as we've highlighted, has a significant focus around health inequalities, particularly those related to drug and alcohol, mental health and wellbeing, and obesity in terms of child healthy weight. The report describes in a little bit of detail how we link and support the activity around the city plan, and the city plan itself certainly acknowledges the important role that the IJB and the Health and Social Care Partnership has in terms of delivering those priorities in the future. We'd intend to align reporting to the IJB in progress around the city plan, and particularly the priority around inequalities with that's been set out for the Dundee Partnership itself. So when they take their annual report to the Dundee Partnership, subsequently we would intend to bring it to the probably the performance audit committee of the IJB just for information as well, and to ensure that people are kept up to date with that. And I'll just stop there if there's any questions.
Thank you, Catherine. I thought it was an excellent report. The only comment before I open it up to others, the only comment I would have was, and this is probably a feature of the fact that we've been in COVID, is just maybe a little bit more about all the good public health initiatives, and also just the reducing the mortality, the premature mortality in some of the more deprived areas of the city. But I did speak to Emma about it, and she said we've just not really, with everything going on in COVID, we want to contribute more to that in the future. But I thought it was an excellent report, so that's my comment. Thank you, Catherine. I've got Annie coming in, and I don't know if that's a legacy hand, Martin, or you have a comment on this. Pass to Annie.
Hi, Catherine, thanks. Fascinating to read, makes me very proud to be a Dundonian. You're probably going to say you're going to do this, but in terms of our strategic commissioning plan, which is next, are we going to be making direct reference and links back to the overarching Dundee plan? Because that would kind of just make sense that what we're doing links in, and we can contribute to the evaluation of that ultimately going forward.
Yeah, absolutely. So in terms of setting some of the context around the national and local policy, that kind of golden thread, that we'll set that out in our own plan. And obviously there's really good alignment already in terms of that priority within the city plan, aligning really well to our health inequalities priority that we expect we'll maintain into the next replacement plan as well. So it'll be quite easy for us to make clear and simple links for that are understandable to us, but more importantly for members of the public who are looking at that and how it all fits together.
Okay, thank you. Thank you for that, Catherine. I've got no other hands up at the moment, so this is for information and endorsement. So are we happy with that? We're just really endorsing something that's been produced that is an important document for us. Okay, so thank you for that, Catherine. We're happy with that, happy to endorse it. Willie?
Yeah, thanks very much, Chair. Item 14 then before you say strategic commissioning plan report.
Yep.
That's me for this one. So again, I'll not spend a huge amount of time on this, but this is a resubmission of a paper that came to the last IJB setting out our proposed approach and timeline for the production of our own replacement strategic and commissioning plan. So I'll draw attention to section 4.2.5 of the report, which is the bit of the report which has been enhanced since the last discussion. You recall last time round, IJB spent some time discussing the status of the strategic needs assessment and how that would inform the planning process. And we did provide some information to you out with the meeting, just to clarify the current status of strategic needs assessment and how that's updated and how it's used in our planning process. And some of that is now reflected in that section of the report. So hopefully that provides the assurance that IJB members were seeking around that particular aspect to allow you to approve the recommendations today.
Okay, thank you, Catherine. Are there any queries, questions, points people want to raise in relation to the commissioning report? Strategic commissioning plan? No? Okay, are we just noting this, Willie?
Thanks very much, Chair. There are 5 recommendations there before you from noting, endorsing and instructing Chief Officer to take action. So if you're happy to accept all those 5 recommendations that they are in the report, that's appreciated.
Yep, I think we're good with that. There we
Okay.
go. Accepted. Okay, Willie, keep moving on.
Okay, thanks very much. Item 15 then before you is the financial monitoring position. It's a report by Dave Berry.
Okay.
Okay, thank you. As with others, I'll pass on to Christine because she wrote the report. She's going to do a brief overview of that. I'll come in as well. So over to Christine.
Morning, Christine. Afternoon.
Yeah, afternoon. Yeah. Yeah. Just a very quick update. This is our standing report. So again, given time, I'll try and be as quick as I can with this one. As this is our financial report based on the information at the end of August for this current financial year. Based on that, the 5 months spent to end of August, we are currently projecting an underspend of £1.74 million for this financial year. Details of the key variances are shown in 4.3 and 4.4, and also details in the appendices at the end of the report. The figures now include an updated expected pay award implication for the Dundee City Council staff following the agreement of the pay offer. So we're now anticipating an increased cost of £1.4 million due to the tapered structure of the pay offer, where the staff on lower salaries are actually getting a significantly higher percentage than the flat 5%. I think that we'd assumed at the last report. So that 1.4 cost implication is built into our position. As you'll probably be aware, NHS Agenda for Change pay award for the current year is still not known, although there has been a recent revised offer has gone out, but we've still not got any agreement on that one. However, we continue to assume that Scottish Government will fully fund the pay award implication for NHS staff. So we're not assuming any additional cost implication for that. Just a couple of points just to highlight from the report. So all the COVID spend, we're having to report monthly on additional costs for COVID, as you'll probably know, back up to Scottish Government. So the cost implications or the projected cost implications for this financial year, as at the end of August, are now about £4.9 million. And as members will know, we hold reserves carried forward balance from last year of about £15.6 million. So we are continuing to work with the assumption that our COVID costs will be fully covered from that reserve. I know Dave's going to come in at the end just with a couple of additional comments about this, but just to continue to highlight that reserve is an earmarked reserve for a specific purpose, so we can only use that funding for COVID, additional COVID cost purposes. And the other points, and just in terms of some changes in terms of the reserves, at the last report we agreed, as we've already mentioned through the meeting, to earmark some additional reserves to fund the GP. So there is a change in section 4.6 to the reserve layout to create that additional reserve and move the funding from operational reserves to dedicated earmark reserve. And obviously then when we come to the next meeting, this table will be updated again to reflect the 150,000 that we've just earmarked for the premises manager. So there'll just be a few changes just to highlight that this will flow through into this report. And also in 4.6.5 and 4.6.4, there is the comments about expectation of our reserves balances will be reduced significantly by the time we get to this end of this financial year, partly from, as Shona has already and David Shaw's already mentioned, in terms of Primary Care Improvement Fund utilising that reserve, and we're expecting sort of similar implications perhaps for some of our other reserves. So there will be, it's just to highlight that the financial report towards the end of this financial year will start to show some of these changes as reserves are beginning to be utilised, and it's just to make members aware from that statutory reporting point of view. If there's any comments, I'm happy to take that, but I think Dave wants to come in just with one or two other comments from sort of national and strategic points of view as well.
Yeah, thanks for that, Christine. Thanks for taking us through the report. So just a couple of points to kind of pick up on. So Christine talked about the kind of local government pay award and the fact we made an assumption in for that and built that into the figures. Just to let the board know that Scottish Government have recently written to local authorities to remind them that the £140 million of additional funding that's been allocated to them includes funding for staff that are kind of delegated to the IJBs. So the expectation is that money is transferred over, so it's not just retained by local authorities, that money is then shared to IJBs as well. So that's kind of really helpful to kind of give us that guarantee that the funding will transfer across from that kind of additional funding perspective. Christine's kind of noted the reserves position. I think for me the really important figure for us in the report is the £9.8 million of uncommitted reserves. So that's what I was referring to previously, and Christine's mentioned in terms of bringing forward some other sort of proposals around the utilisation of that. The one sort of kind of word of caution I'll have around that though is as we start to present information to you around the budget for 23-24 is around how much we may need to kind of set aside to kind of get us through what's likely to be a kind of very challenging year financially next year. So I think we need to get a kind of balance between making sure we have proper investment in things that are going to improve service provision and our infrastructure, but also kind of one eye on next year as well. But we'll discuss them in a bit more detail at the time. And the other thing just around the COVID kind of spend position that Christine set out, and we have noted in the report that we have received a letter from Scottish Government noting their intention to recover any surplus kind of COVID reserve funding from IJBs. At the moment, we don't have the detail in terms of what the mechanism is going to be around that return of that funding. But what I can say to the board is that we have the guarantees that we will have all the funding required to cover our COVID spend. As Christine says, it can only be spent on COVID and for delegated services. So, if we're not spending it on that, we can't spend it on anything else. So, just to give the board some kind of reassurance there that there's not any financial risk to us of that funding going back once Scottish Government actually then kind of take the next step to kind of inform us the methodology and how basically they're going to go about that. So that's just a kind of couple of wee additions to the report for assurance to the board. So again, happy to answer any questions.
Okay, thank you for that, Dave, and thanks, Christine, for taking us through it. Dorothy's got a question, I think.
Yes, a quick question for Dave, please. Thank you for that explanation. Did I understand you to say that you can use reserves to produce a balanced budget?
Yes, so the IJBs, so the reserves the IJB holds are, apart from those that are already ring fenced, so the ones that are related to things like primary care and ADP and mental health, etc. The IJB has can do what it wants with that, with those reserves. We have in the past, a number of years ago, kind of used some of our reserves to kind of so we didn't have to kind of put as many savings into the system in one particularly challenging year. Now, the issue with that, of course, is it just buys you time because it's a non-recurring saving. But in line with local authorities do the same, they'll maybe utilise some of the reserves to kind of give them, so they don't need to kind of provide as many savings into the system. So it is one of the tools that's open to us, Dorothy, into the 23-24 budget.
Thank you for that. I just needed that explained because I know there are other budgets within the council where, well, particularly the housing revenue account, where reserves can't be used to produce a balanced budget. But in this case, you can use the reserves in that way. Thank you.
I have a question, Dave, and it's around the delayed discharges, and could we contribute to the cost of the delayed discharges using some of the reserves that we've got? I mean, the reason I'm asking that is they're our patients and we cannot necessarily put them in social care placements or provide step-down beds in the community. So they're inappropriately still cared for in an acute bed. As I understand it, Angus recognised that in their IJB decision-making processes, and they have identified the need to provide some financial support to cover the cost of that. And I'm just mindful of the fact that if we can't provide it in social care or in home care support, should we be offering to provide some financial support to the board who are opening beds that they are not funded for? And it's a question, and I would maybe ask other members of the committee what their thoughts are around that. I'll let Dave come back in, and then Jenny's got a hand.
That's okay. I wasn't aware that Angus had kind of made a contribution on that particular issue. I know that from speaking to my counterpart and Angus, it was kind of recognition of the scale of their reserves that they had, and also a general contribution, but I'm not sure how they've badged it up around that. I would not be advocating that's what we do. I think it's a dangerous precedent that we might go down. It's never been done before in terms of kind of being billed for around delays, and indeed under the large hospital set aside arrangements whereby the unscheduled care pathways is in effect part of the IJB strategic planning side of things. The resource release that NHS Tayside have provided back to Dundee being the only partnership in Tayside that's actually had the resource release from large hospital set aside, we agreed it, but it was significantly less than the number of unscheduled bed days, which was the measure around large hospital set aside, that have been freed up within Dundee since the benchmark back in 2016. So from our perspective, there's in effect a NHS Tayside was funding for that in the first place, that would allow us to then kind of invest further in community-based services to then, in effect, kind of assist us with tackling the delayed discharge issue.
If I can just come back there before I let my colleagues come in, as I understand it, right, we want those patients looked after in the community or at home or in a step-down type facility, whether that's a care home or it's something that we're providing. But we can't do that because we don't have the capacity, albeit the capacity is slowly improving. But at this present time, these patients cannot be in that setting of care because we physically cannot provide that. Now, they've got to go somewhere, right? If they're not well enough to go straight home without support. So it feels like an ethical issue a little bit to me, in the sense that if they've got to go somewhere, they're in a bed. Admittedly, it's not the right place for them to be. But we're not. I mean, if this was if this was Care Homes PLC, if it was Pat Kilpatrick Care Homes PLC, and I was taking your 50 delayed discharges, I would be charging you per occupied bed day. But because we're all part of the one system, we're not doing that. And I just wonder if that it doesn't feel right to me, but I'll let others come in. I've got Donald, and then I'll let Jenny come in. Donald.
Yeah, thanks, Pat. I mean, really just following up, and it's a really difficult question. And I think, in the first place, as members of the IJB, it's not necessarily for us to get our checkbook out and send some cash off to NHS Tayside on this one. But I think our responsibility is really to look at the whole system that provides support to the people of Dundee, and so there's a balancing piece there. So as I say, while we wouldn't necessarily want to get our checkbook out straight off, I think we should at least be willing to entertain a request and engage with a request that might come, rather than perhaps dismissing it out of hand. I think it's something that we need to listen to, we need to think carefully about, and we need to think about it from the perspective of how will this help the health of the people of Dundee. I mean, the reserves question is an interesting one. I think where it's nice to be in the position where we have reserves to talk about, because that hasn't always been the case. And there's a balance here between retaining it in the kitty for a rainy day that may or may not come, spending it, and not spending it for the sake of spending it, but spending it for purposes, again, that are for the benefit of the people of Dundee, and above all, avoiding being in the position where we don't use money and it gets clawed back for non-use. So I don't think it's one that we can solve today, but I think it's a discussion that will need to come. And I think, well, it won't be me at the time, it will be a different board, but I think it's you should certainly listen to the question. Thank you.
Thanks, Donald. I'll let Jenny come in, and then I'll go back to Dave.
Three things. I suppose the first one was just to say, when we look at those delay numbers, it's only a small proportion of them that are in 9 wells. Most of them are actually within partnership facilities like RVH and Kingsway, because we try and keep the acute flow clear by moving people downstream into these resources. So it's not a matter of we've got 60 people, it's about that across Tayside. But for Dundee, I think our aim was to get to 15 last week in 9 wells, and it was 17. We aim for that to be down to 10 this week. I suppose the second bit of that was in relation to, as long as you invest in beds, you fill them, and then the underlying problem doesn't go away. So we did that throughout COVID when we increased the capacity by 1 ward in RVH, and then we opened intermediate care in Mingus Hill. And because you're not getting rid of the underlying issue, which is about social care availability, you just fill them and then you hit the next wave. So I think our best way to support, and I'm about to say 2 things that are in complete contradiction, our way out of this is to support our strategic direction and invest in the community resources. And just to provide that assurance, we regularly turn Dave upside down and shake him. But we're running out of things that we can think of to spend the money on, because it's now not so much an issue that's about money, it's about actually physically finding people. So I think we need to look more into things like technology, managing the levels of demand, managing, the early intervention to prevent people deteriorating. We know that people need less care before they go into hospital than when they come out. But yeah, it's a pretty intractable problem.
Okay, thanks, Jenny. I mean, I suppose 17 getting down to 10 is good, but 17 is still almost a ward, and I don't know what I ward years and years ago. I could tell you what awards, what it cost to run a ward, and it was a lot. You're talking about millions, but 17 patients is almost a ward, but if you say you're getting down to 10, then that's good. What I'm really saying is echoing what Donald said, which is I think we need to have that conversation, and I think NHS Tayside will be keen to have that conversation with all IJBs, and I think we're not any different in that respect. I'll let Dave have the final say on this, and then we really do need to move on.
Yeah, and thanks for that, Pat. And Jenny picked up on kind of one of my main points here around, well, actually the best out of it for our sake is to actually invest in kind of in community-based services. That's what we need. And as Chief Finance Officer, whose primary focus is on the Integration Joint Board and meeting the kind of objectives and priorities of the board, that's where I would be kind of steering the board's kind of views, because if the money, we are going to need that funding in future years, because next year, as I say, it's likely we're going to have significant budget challenges. We already kind of start to kind of calculate in the range of pressures, and indeed our kind of financial framework that we presented back to the board back in June, and this was before inflation started hitting record highs, and we were looking at possibly around about a £9 million shortfall for next financial year. So with that sort of backdrop, I would not want to be volunteering to be kind of transferring funding out unless there was a very strong business case for it. In terms of, and perhaps as Donna says, I mean, if there's a proposal put forward to us as a board from NHS Tayside to consider, then we would consider that. But at this point in time, I would not be kind of proposing that we volunteer to hand money over to NHS Tayside for those particular reasons.
My understanding, Dave, was that you were in discussions with them. I don't know whether it was a formal proposal, but my understanding was that NHS Tayside's Finance Director was in discussion with all IJBs about possible use, short-term, 1 year only, of reserves to try and fund some of the additional beds that they were opening. But I don't know the detail. I'm not operational, so I don't know the detail of that. If there are no other questions or no other points that anybody wants to put forward, what do we have to do with this, Willie? Do we just have to note it? We have to agree it?
Yeah, thanks very much, Chair. Yeah, there are 3 recommendations here before you, and all 3 of them are for noting.
So it's just for noting. Okay, that's very helpful. Thank you, Dave, for that. Right, Willie, move us on.
Okay, item 16 then is implementation of the public sector equality duty. It's page 179 of your agendas.
Yeah, that's Dave.
Well, I think I'm going first and Dave will chime in. Given the timing and members needing to move on to other meetings, Pat, I just wondered whether, in the assumption that people have read the paper, it's helpful for me not to say anything by way of introduction and just use the time for questions.
Yeah, that's helpful.
Okay.
Have people got, assuming everybody's read it and looked at the points, any points they wish to raise? What were we asked? No, there's no questions. What were we asked to do with this, Willie? We were asked to note it, agree it, sign it off.
Yeah, thanks very much, Chair. If you wish, I'll read out the recommendations there. From 2.1, you're asked to note the content of the report. 2.2, note the feedback received from the Quality and Human Rights Commission following their recent IJB compliance audit, including concerns regarding the sufficiency of information contained within the IJB Integrated Impact Assessment, section 4.2 of the report. 2.3, note the improvements already made to the publication of IJB equality information and in partnership with Dundee City Council to the Integrated Impact Assessment process and tools, sections 4.2.2, 4.3.1 and 4.3.3 of the report. To note further planned improvement activity in relation to the completion of integrated impact assessments, including learning and development and quality assurance actions as outlined in section 4.3.5 of the report. And finally, instruct the Chief Officer to submit a further report updating the IJB and the progress of improvement actions no later than 28th of February 2022.
Okay, all agreed? We're happy with that? Yep, okay. Right, moving us on, Willie.
Okay, takes you on to item 17, category 1, responded action plan, page 185 of your agendas.
With me again, similar to the last report, Pat, I'll just suggest that we take questions. We're just looking for you to note the content of the report, approve the action plan that's in the appendix, and instruct the Chief Officer, the Finance Officer about this updating the strategic risk register, and the Chief Officer in relation to bringing back the annual assurance report that's covered in the main body.
Okay, can we agree those actions? I've got any questions? I see Diane on screen, so she's presumably come on in Vicky's place, see if there's any points. I think we're generally happy with that. It's not a contentious area. Okay, Willie.
Okay, takes you on to item 18, Meetings of Integration Joint Board over 2022 attendances. The shaded areas on the item should be extended to reflect 24th of August.
Yeah, I see Martin's got his hand up because I think there's maybe one or two
inaccuracies in that. Just to say that I noted that when reviewing the papers that there was a number of tick marks against people who are no longer here and things of that nature. So I just wanted to highlight that. That was all.
And Christina's got her hand up too.
Hi, actually just to say now that we're in a position within DVBA to, attend regularly and have a rep, but I would welcome a meeting to talk about what's required of the third sector representation in relation to the IJB's terms of reference. And is there room also for a deputy so you get consistency? And just wondering, is there any representation on some of the governance committees around it? So maybe that's something I'll take offline. But I'd welcome a meeting in relation to the expectation of the sector.
Okay, I think that'd be helpful. We could set that up, Willie, couldn't we? Would that,
Yes,
would that be Dave? Would that be Vicky? Would it be Diane? I don't know who that would be with.
Yeah, certainly advise the Chief Officer accordingly, but certainly there is provision there for proxy members to attend in place of the named representative on the IJB.
Yeah, and can give Christina guidance on what other committee opportunities there are to play a part for that. Is that okay, Christina?
Yeah, that'd be great. Thank you.
Thank you very much. Okay, Willie. Are you still there?
Yeah, sorry. Finally, the date of the next meeting is 14th of December 2022 at 10 AM.
14th of December, right, at 10 AM.
10 AM.
Yeah, that's good. We're sorted. I'd like to thank everybody for your patience and good-natured input today to the meeting. It's been an interesting agenda. My great thanks to Willie as ever for keeping us right on a number of things and steering us through the agenda. Your input is much valued, Willie, and to all of the senior officers who contribute papers and input, including those such as that have appeared today, who don't always have to be presenting their own papers but are coming in and presenting colleagues' papers for them. So we're very grateful for all that input and support, and want to thank everybody for their contributions today. We now officially declare the meeting closed. Thank you, everybody.
Thank you.
Thank you.
Thanks very much. Bye, everyone.
Thanks. Bye.